I'll call him once and then we start.
No, that's okay. We'll start.
Yes. Sir, Namaskar. Good afternoon.
Namaskar.
Good afternoon. Good afternoon, everyone.
So, are we ready to start?
Yes, sir.
Yes, we are waiting for you, Ashok.
Acha, sir. Sir, good afternoon, everyone. And we are here with the Odyssey of Teachers once again, another episode. And and today we are here with ATCOM, that is Attitude, Ethics, and Communication. So ATCOM is very important aspect of today's learning. And whenever we are dealing with the medical education or whenever we are dealing with the patient care and whenever dealing and we are concerned with NMC also, ATCOM is an important and integral part of the curriculum also. Earlier days, we never had classes on these type of topics, and we just used to understand from each other. But now there are formal classes and formal teaching methods and learning methods about attitude, ethics, and communication skills. So with these ATCOM modules, we are here today to give some information that how to go about, how to teach our students, and how these skills can be useful for our learning when we are dealing with the patients. And it is also important when we deal with our colleagues also, our juniors or seniors or our fellow colleagues. So this is now basically has become a part of our behavior. So and people are judging on your behavior. So it is like you have to be very careful when you are dealing with public, when you are dealing with patients, even when you are dealing with your seniors and juniors also. So this learning method in the series of Odyssey of Teachers, we are here and we have many eminent faculty from all our country to take part and to demonstrate you by live videos also that how to communicate or how to follow these practices. And before we proceed, we have our chairperson, Dr. Parag Biniwala with us. Before that, I just wish to express our sincere gratitude to Foxy President Dr. Sunita Tendulkar and obviously Dr. Parag Biniwala and Secretary General Dr. Sarita Balerao for giving us this opportunity to have this program under the banner of ICOG. And we always try to invite many teachers from different parts of the country to have a role in this module. So I invite Dr. Parag Biniwala to say a few words.
Thank you, Dr. Ashok. Good afternoon. I bring greetings from ICOG, and it's indeed a pleasure to address the gathering today on this episode of Odyssey of Teachers. So, as Dr. Ashok has said, today we are going to cover an important module of EdCom, and I must appreciate the efforts put in by the conveners of this activity, Dr. Ashok Kumar, Dr. Vidya Thobi, who's our governing council member and a very prominent teacher from the state of Karnataka, and of course, Dr. Vandana Agarwal, our very young, enthusiastic member from Delhi. Today's sessions are going to be interesting, and I'm thankful to all the faculty who are going to take part today. Dr. Vidya Thobi, who will be opening the session, and then we'll have 4 video sessions where we have Colonel Sirisha and Dr. Rachna Chaudhary, Dr. Pradnya Changede, our own Vice Chair-elect, Dr. Sheila Mane, Dr. Uma Gupta, Dr. K. Pushpalata, Dr. M. Anuradha, and Dr. Mukta Agarwal. All of them are eminent professors from various institutions, and I'm sure today's session will be a great learning experience for all of us. So thank you very much and my best wishes for the program. Let's move ahead, please.
Thank you, sir.
Thank you, sir. Thank you so much. Before we proceed further, also, I would like to thanks and would like to highlight the contribution by Professor Vidya Thobi and Dr. Vandana Agarwal in organizing this series. And also, I would express my sincere thanks to Professor Sheila Mane, Madam, who is the chairman elect ICOG, for her continuous support for all our endeavors. So I now hand over the uh, proceedings to Professor Vidya Thobi, Madam. She will introduce all the faculty and continue with the program. And I also would like to express my thanks to all the faculty and all the institutes for sparing their valuable time for this series. Thank you very much. Dr. Vidya Thobi, Madam, please.
Yeah, and we all of us would like to thank MCure Zenex division because they have really helped us in shooting all the videos which are going to be part of today's program. Thank you.
Uh, Thank you very much and welcome to this Odyssey of Teachers Module 3. And it is very interesting and I must thank Dr. Ashok Kumar. It is a brainchild of these all modules and especially I must thank Dr. Vandana Agarwal who has done basic all backbone and homework throughout these all modules. So thank you, Dr. Vandana. I thank equally our President, Dr. Sunita Tandulwadkar, then Dr. Suvarna Khadilkar, as well as Sarita Bhalerao, who is ICOG Secretary, and all the contributors for the today's module. And Dr. Sheila Mane is also having one module, and she will be there, I think, shortly. She is not there in the audience. I welcome all for this module, and I would like to introduce this ATCOM module first, what it is. And as Dr. Ashok Kumar has labeled this, if you can't explain something simply, you don't understand it well enough, as Albert Einstein says. So earlier we used to see our professors, our students, everyone, how they behave, how they teach, how they treat, and then we used to imbibe those qualities in us. So now it has got a properly, it has shaped into one module. And I again thank everyone for giving me this opportunity for taking this forward. So greetings from ICOG to everyone and hope my screen is visible. Is it visible? Vandana?
Yes, ma'am.
Yes, yes. So thank you very much. And what does this ATCOM means? Means attitude, A for attitude, E for ethics, C for communication. That is what ATCOM means. So the practice of medicine is an art, not a trade, a calling, and not a business in which your heart will be exercised equally with your head. So that is the William Osler's saying, and definitely it does matter. So ADCOM stands for Attitude, Ethics, Communication, which is developed by the National Medical Commission as a part of competency medical education, that is based medical education. That's what we call it as a CBME, which is shifting from knowledge based training to developing the specific skills and communication in medical students. So all of us know this that the communication skills nowadays are lacking and it sometimes becomes very difficult to address the students also. So it addresses the affective domain of the medical education, emphasizes empathy, a professional attitude, ethical decision making, and the communication, which are considered very, 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 very crucial for the students to develop these attitude as well as ethics is very important part. It is designed to produce a well-rounded medical professional, whatever the curriculum that not only possesses the strong clinical knowledge, but also the essential qualities to deliver comprehensive and ethical healthcare. So these skills are to be imbibed by each and every students student who is Indian medical graduate. Now it has been changed to the Indian medical graduate. So what is a role of an Indian medical graduate or in the competency based medical education? One is clinician. He should be good clinician, good communicator. He should be leader. Professionalism should be there with him. He should be lifelong learner. And to play his her multifactorial role, ING, that is Indian medical that graduate requires a wide range of competencies, of which ADCOM is a core competency. Now, this is a Bloom taxonomy. Who was Bloom? Bloom was a Benjamin Bloom in 1956 in University of Chicago. He brought down these three domains of learning. First is a cognitive domain, that is he should have mental skills and intellectual development. Second is a psychomotor, that is the emotional attitudes, values, and appreciation. Third is the affective domain, that is a physical coordination and motor skills. So all these three things he should learn. Now, this first let us know what is cognitive domain. Now, cognitive domain has got lower order thinking skills and higher order thinking skills. So, one thing is he should remember, recall specific fact about the, and he should have a knowledge about it. Then understanding comes after he remembers. He should grasp the meaning of the instructional material, use information in a new but the similar situation. So he has to apply this knowledge, and then he should analyze, take apart the known and identify relationship, evaluating, examine information and make judgment, then creating, use information to create something new. So in the research, he can apply in the research or he can create his something new. So it has got a lower order and as well as the higher order thinking skills. Now, what is the affective domain? Now, affective domain has got many things. One is he's receiving this level is necessary for learning to know and apply. The second one is learning to occur. The second one is responding. When you learn, you have to respond, and the students participate in this learning process. And third one is students this attach, that is valuing. The students attach value to the information they have learned. And fourth is organizing. Students can organize the ideas and information they have learned. Students can attempt to build and abstract the knowledge. So this is affective domain, and this domain focuses on the ways in which we handle all things related to emotions such as feelings, value, appreciation, enthusiasm, motivation, and attitudes. Now, methods of teaching, one cognitive domain, how you can use this as a group discussion, seminar, case-based learning, brainstorming, jigsaw method, etc. So if you have seen our previous modules, we have used all these things. So you can, of course, visit ICOG online and also and go through this. The second one is the psychomotor domain, in which we have workshops, bedside teaching, demonstrate, observe, assistant, perform, that is dope, simulations, skill labs, etc. Then third is affective domain, role plays, feedback, observation of role models, reflective thinking through experience sharing, documenting, creative writing, and art-based interventions. So this is an affective domain. We are having few of them in today's module. Then comes the medical ethics, very, very important. It has got four pillars. One is autonomy, beneficence, non-maleficence, and justice. So this is very important. Whenever you are doing, am I doing whatever is best for the patient? First question. And second is, am I protecting the basic right of the patient? These are the two important part of medical ethics. Now, medical ethics is built on four key principles. So that's what we always teach them, that autonomy, beneficence, non-maleficence, and justice. So ethical dilemmas arise in areas like end of life care, euthanasia, patient confidentiality, informed consent, and resource allocation, which requires balance between patient rights and medical responsibility. Now, bioethics addresses modern challenges, including artificial intelligence in medicine, gene editing, and the ethical implications of cloning and stem cell research. A strong understanding of medical ethics is essential for practicing medicine with integrity, compassion, and fairness. These principles serve as a guiding pillars for ethical decision making, helping healthcare professionals navigate complex situations. Now, autonomy, it refers to the patient right to make its own healthcare decisions. This principle honors individual freedom, ensuring that the medical choices reflect the patient values, benefit, and preferences. Now, informed consent is very, very important, is a key aspect of autonomy. The healthcare providers must offer patients detailed information about the treatment options, what are available, the risks and benefit to help them to make educated decisions. So you have to inform, means everything about whatever the procedure, whatever treatment they are taking in their own language. And this is a pivotal in case like end of life decisions, refusal of treatment, or selecting elective procedures. So this is very, very important about the autonomy. And respecting autonomy means honoring the decision, even if, this is very important again, you listen to this, even if doctor personally disagrees. So many times it happens that the whatever treatments are available, what is the best treatment, doctor can tell them, but sometimes the patient has got autonomy to refuse also. The autonomy should not be sacrificed at the altar of medical paternalism. Now, there is a tendency among young men about the hospitals to study the cases, not the patients, and in the interest they take in the disease, lose the sight of individual, strive against this. So, what is beneficence? It requires that the healthcare providers act in the patient's best interest, promoting well being and positive outcomes. It goes beyond avoiding harm, requiring active efforts to do good, from recommending the most effective treatments to provide the compassionate care. Non maleficence, it means do no harm. Healthcare providers must avoid causing unnecessary suffering even when trying to help the patient, and they should carefully weigh the potential risks and benefits of the treatment intervention to ensure ethical decision making. So, justice is a medical ethics ensuring fairness in the distribution of healthcare resources, access to the treatment, and decision making, and it requires the care which is provided without discrimination, balancing the individual needs with the broader societal context. Now, veracity is a truth telling. The truth may hurt for a little while, but a lie hurts forever. Though it is not always easy or even possible, there is much to be gained by the always striving to treat the patient, not the disease. So, for everything, there are examples, but because of paucity of time, I'm just completing. We will discuss this in the whole module, whatever we are discussing today. Communication is a bedrock of the patient provider relationship. How you communicate can either build a trust or create a barrier to the effective care. Now, communication with the patient, one is gathering information, you have to listen to them. Relationship building is the next, and the shared decision making after discussion and communicating them. Intra and interpersonal communication comes in this context. Professionalism and reflection is very, very important. And communication in healthcare team, professional communication is also an important part of communication. So, what are the principles of communication? It should be concise, clear, clarity should be there, correct, coherence should be there, courteous, complete, and concrete. These are the principles of communication, and a patient should always feel valued, heard, and respected. One should develop that sort of communication with the patient. They demonstrate the ability to communicate to the patient in a patient, and it should be a respectful, non-threatening, non-judgmental, and empathetic manner. Now, what should be a conduct of ideal doctor? You should use of a clear, unambiguous, plain language, exploring patient's understanding, uses interpreter if required, if the language is a barrier, and ask for the patient's permission to proceed. It can be a verbal or written as required. Checks the patient understanding at the regular interval, demonstrates courtesy and consideration to the patient and any assisting staff. shows awareness of the patient's privacy needs and demonstrates empathy, identifies, labels, validates patients' and families' emotional responses, communicates accurate information to empower decision making. So, all these are very important. Now, Kalamazoo's consensus statement assessment tools are there for this, and this statement provides a working model of teaching communication skills and may be used to impart communication skills. It includes seven core communication competencies and 24 sub competencies. And learners' performance is rated at the competencies and sub competencies using categorical rating. Done well, needs improvement, and not done, not applicable. So these consensus came into action in 1999. It has been used to undergraduate and postgraduate medical education and other healthcare education programs nationally and internationally, as well as in various research studies. Now, there are various versions for the clinician, faculty, patients, peer facilitators, and you can do self-assessment. So builds a relationship, opens a discussion, gathers information, understands the patient's and family perspective, shares information, reaches agreement, and seventh is the discussion and closure. These are the communication checklist and demonstrates empathy and communication, accurate information. So this is what Kalamazoo's communication skill assessment form is. You can download this and you can fill it and assess. Now, ATCOM competencies, this is you can have a rating for this communication skill rating scale, which is adopted by this Kalamazoo's consensus statement. And these are the criterias, and you can give the score. Rating is 1 to 3, poor, 4 to 6 satisfactory, and 6 to 10 superior. So these are the criteria, that is builds relationship, opens a discussion, same as above, gathers information, understands the patient's perspective, shares information, manages flow, and overall rating. So remodeling as mentors and observe the faculty, educating future generations of physicians is one of the privileges and obligations of the medical profession. As an important part of this process, doctors historically have patterned their activities on those practitioners whom they respect and trust. These have been called as role models. Always everybody has got role model in their practice, in their whatever the behavior, everything. And the individuals admired for their ways of being and acting as a professionals. Both consciously and unconsciously, we model our activities on such individuals. So role modeling as mentors observe the faculty. So this is a process. So one is active observation as a role model, making unconscious or conscious, we have imbibe their proper whatever the behaviors, and reflection and abstraction, translating insights into principles and actions, and generalization and behavioral change which occurs. So unconscious incorporation of observed behaviors and active exploration of affect and values. So this goes in circle, and it is a vicious cycle. So we also like Swami Vivekananda is one person whom I admire, and we take very every means every line of this his into behavior. So like that, every person has got in his dictionary one more role model in to follow. The process of role modeling is like this. We must acknowledge that the most important, indeed the only thing we have to offer our student is ourselves. So we should look into ourselves. Everything else they can read is in the book. So book is not only things that teachers should also become role models. So this is the end of my slides, and thank you very much for the patient listening. And I hand over now to Dr. Vandana for future proceedings and the next our next session. Thank you
Yes.
very much for the patient listening.
Thank you so much, ma'am, for the wonderful talk. So now may we please have the CVs of our next experts of the first session, which will be on role play on contraception counseling. May I please invite Colonel Sirisha Anne, ma'am? Can we have a CV, please? Yes. Madam is Professor of Obstetrics and Gynecology at AFMC Pune. She is alumni of AFMC Pune. Her areas of interest are endoscopic surgeries and infertility. She has been awarded the General Officer Commanding in Chief in January 2021. She has numerous publications in national and international journals and is a reviewer of the Journal of Obstetrics and Gynecology of India. Welcome, Madam. Dr. Rachna Chaudhary, ma'am. Madam is Professor and Head of the Department of Obstetrics and Gynecology of LLRM Medical College, Meerut. She is a member of the National Academy of Medical Sciences since 2010, Medical Education Unit and District Medical Board. She is a principal investigator of HRRC, ICMR, SIF, PSA, Vishakha, and RLBSK. She is a master trainer state of RRTC, CAC, PPIUCD, lab ligation, RTI, and HIV, and is examiner of various universities across India. Welcome, madam. So we maybe please have the role play video on contraception counseling. Please start the video, Shreya. These are all the students who have participated in the video. Very hard.
नमस्ते मैडम।
नमस्कार। नमस्कार मैडम। क्या नाम है आपका?
जी मैडम, किशन, ये हमारी पत्नी है।
जी सावित्री मैडम।
अच्छा, बताइए सावित्री, कैसे आना हुआ?
मैडम वो हम ना बहुत दूर गांव से आए हैं।
हाँ।
हमारी एक समस्या है, कृपया करके उसका हल बता दीजिए। बहुत बहुत मेहरबानी।
बिल्कुल, बताइए ना।
हमारे मैडम 2 छोटे छोटे बच्चे हैं और वो काफ़ी काम रहता है खेत में, और सावित्री का भी।
मैडम ये 2 बच्चा लोग को संभाल के फिर खेत भी संभालो, खाना भी बनाओ, और बच्चे नहीं चाहिए मैडम। हमको कोई उपाय बता दीजिए। हमारा छोटा सा घर परिवार है, उतना ही रखना चाहते हैं बस। कोई उपाय है तो आप बताइए ना मैडम। इतना दूर से इसीलिए आपके पास आए हैं।
बिल्कुल सावित्री, पहले तो बहुत अच्छा किया कि तुम ये चीज़ के लिए हमारे पास पूछने के लिए आए। पहले मुझे अपनी उम्र बताओ।
35 मैडम।
35। और तुम्हारे 2 बच्चे हैं?
जी जी मैडम, 2 बच्चा लोग हैं हमारा।
तो सावित्री, फिर ऐसे में तो तुम्हारा पूरा परिवार तो संपूर्ण है, तो तुम्हारा ऑपरेशन कर देते हैं।
नहीं मैडम, ये ऑपरेशन हमारे घर वाले सब मानेंगे नहीं। ये गांव में सब बहुत मना करते हैं घर वाले पर। नहीं मैडम, हमारा ऑपरेशन तो नहीं कर सकते हैं।
ओके, तो अगर आपका ऑपरेशन नहीं कर सकते तो किशन भी ऑपरेशन करवा सकता है।
क्या हमारा ऑपरेशन?
हाँ बिल्कुल किशन।
क्या बात कर रहे हो मैडम जी, क्या बोल रहे हैं? चलो सही। और
अरे रुको, बैठो, समझ गई मैं, तुम्हें ऑपरेशन नहीं करवाना है। ठीक है, तो एक और हमारे पास ऑप्शन है कॉपर्टी के बारे में सुना है?
हाँ, वो शांता बहन बनवाई थी ना।
अच्छा, वो
हाँ वही है।
देखो ये कॉपर्टी है, अगर इसको मैं तुम्हारे गर्भाशय में डाल दूंगी तो तुम्हारा बच्चा नहीं ठहरेगा। और ये 2 अलग अलग प्रकार की आती है, एक 10 साल के लिए है, एक 5 साल के लिए है। तुम तो ऑलरेडी 35 साल की हो गई हो। अगर मैं 10 साल वाली कॉपर्टी डाल दूंगी तो अगले 10 साल तक का आराम हो जाएगा, उसके बाद तो मासिक धर्म वैसे ही बंद हो जाएगा।
नहीं मैडम, वो शांता बहन लगवाई थी, बहुत परेशान हुई थी। वो बोली मासिक बहुत ज़्यादा आता है, पेट में दर्द भी होता है, फिर उनको निकलवाना भी। नहीं मैडम, ये कॉपर्टी हमसे नहीं हो पाएगा मैडम।
अरे सावित्री देखो, इतना छोटा सा ये चीज़ है, शुरू के 2-3 महीने थोड़ा सा ब्लीडिंग ज़्यादा रहेगा, पर मैं हूँ ना, अगर कुछ ज़्यादा प्रॉब्लम होगी तो तुम्हें दवाई दूंगी, उसके बाद ये एडजस्ट हो जाएगा तुम्हारे शरीर पे।
मैडम जी, इतना दूर से गांव से कौन आएगा शहर बार दवाई लेने के लिए? ना हो पाएगा मैडम। खेत पे काम कौन करेगा फिर?
अच्छा ठीक है,
नहीं होगा। कुछ और अच्छा उपाय बताइए।
बिल्कुल, अगर तुम्हें ऑपरेशन भी नहीं कराना है और कॉपर्टी भी नहीं लगाना है तो हमारे पास एक पिल्स आती हैं, वो गोली रोज़ दिन में 1 बार खानी होती है, 28 दिन की गोली होती है। उसके बारे में तुम्हें थोड़ा सा बताती हूँ, जानना चाहोगे?
जी मैडम। आप बोल रही है गोली में क्या होता है मैडम?
गोली देखो ना, ये माला N और माला D के नाम से सरकार ने इशू करा कर रखी है। ये जो दवाई है ये इसमें 28 गोली रहती है। इसमें से 21 गोली जो है इसमें हार्मोन रहता है, मतलब दवाई रहती है, और बाकी 7 दिन के लिए खून बढ़ाने वाली दवाई रहती है। और इसके पीछे देखो कितना अच्छे से इन्होंने बताया है कि इस दवाई को खाना कैसे है। पीछे से यहाँ से तुम दवाई शुरू करोगी अपने मासिक धर्म के पहले दिन से, और उसको ऐसे खाते खाते तुम 21 दिन पूरा कर लोगी। 21 दिन के बाद तुम अगले 7 दिन के लिए ये नीचे वाली दवाई खाओगे, जिस बीच में तुमको ब्लीडिंग होगा, मासिक धर्म आएगा। उसके बाद अगले ब्लीडिंग के दिन से, पहले दिन से फिर से तुम ये दवाई यहाँ से शुरू कर दोगी।
ये गोली रोज खाना पड़ेगा मैडम?
हाँ, ये दवाई तो
गोली खाना ये बच्चा लोग संभालते कहाँ याद रहेगा हमको गोली रोज खाना है।
अरे कोई बात नहीं, हम याद दिला देंगे मैडम, कोई बात
अरे सावित्री देखो किशन कितना समझदार है, तुम्हारी पूरी हेल्प करने के लिए तैयार है। अभी अगर हम ऑपरेशन भी नहीं कराएंगे, कॉपर्टी भी नहीं लगवाएंगे, तो अभी हमें अपने लिए कुछ अच्छा इस्तेमाल करने का तो सोचना पड़ेगा ना। तो इसको चुपचाप से अगर तुम सिर्फ एक बार दिन का समय निर्धारित कर लो, उस टाइम पर खा लो, किशन तुम्हें याद दिला देगा।
और कभी भूल गए तो फिर क्या करेंगे?
देखो अगर तुम इसकी एक गोली भूल गई तो अगले दिन तुम्हें 2 गोली लेना पड़ेगा। पर मान लो अगर तुम 2 दिन लगातार भूल गई दवाई लेना, तो फिर तुमको एक नया पैक शुरू करना पड़ेगा दवाई का, और अगले 7 दिन के लिए कॉन्डोम का इस्तेमाल करना होगा ताकि गलती से भी बच्चा ना ठहरे।
अरे तो मैडम फिर कॉन्डम ही क्यों ना इस्तेमाल कर रही है पूरा टाइम? वो तो अच्छा है यार।
बिल्कुल किशन, मैं तुम्हारी बात समझ रही हूँ, पर अब ऑलरेडी सावित्री के 2 बच्चे हो गए हैं। अभी क्या तुम कॉन्डोम के साथ थोड़ा सा भी रिस्क लोगे? इसमें और कॉन्डोम में बहुत फ़र्क है। इस दवाई का ज़्यादा इफेक्ट रहेगा और कॉन्डोम का टूटने का डर रहता है। ऊपर से इस्तेमाल की भी कोई गारंटी नहीं है, कोई यूज़ कर रहा है नहीं कर रहा। ये अगर तुम नियमित रूप से लोगे तो तुम्हारी प्रेगनेंसी ठहरने का चांस 1% से भी कम है।
और ये गोली हमको पूरा जिंदगी भर खाना पड़ेगा मैडम? तो इसमें तो बहुत पैसा लगेगा। हम तो बहुत गरीब परिवार से है, कैसे कहाँ से खरीदेंगे ये गोली हम?
देखो सावित्री, ये मालाइन के नाम से जो दवाई आती है, इसकी तुम सोचो कितनी कीमत होगी।
आप ही बता दो मैडम, हमको
ये एकदम निःशुल्क है।
अच्छा,
तुमको एक भी पैसा नहीं खर्चना है। और मान लो कि तुम कभी कहीं ऐसी जगह फंस गई जहाँ तुम्हें ये दवाई नहीं मिल पा रही, तो मालाडी के नाम से ये दवाई आती है, जो कि 5 रुपए से कम में तुमको एक पत्ता मिल जाएगा। तो महीने का अगर 5 रुपए से कम के खर्चा तुम अपने ऊपर कर ही सकती हो।
इससे और कोई अच्छा तरीका है क्या मैडम?
इससे भी अच्छे तरीके भी हैं। अगर तुम्हें रोज दवाई नहीं खानी है तो 3 महीने में 1 इंजेक्शन लगा सकते हैं।
नहीं, इंजेक्शन से हमको डर लगता है मैडम। आप ये गोली के बारे में और थोड़ा बताइए ना।
हाँ, तो ये गोली का जैसे तुम्हें मैंने बताया कैसे खानी है, उसके अलावा हमें कुछ चीज़ें जाननी होंगी। तुम्हारी किसी फैमिली में तुम्हारी मम्मी को या तुम्हारी बहन की तरफ किसी को खून गाढ़ा होने की दिक्कत या रक्तचाप की दिक्कत या कोई लिवर का या हार्ट का कोई प्रॉब्लम या कैंसर का कोई प्रॉब्लम।
रमेश चाचा जी के भाई के बेटे को था ना?
नहीं सावित्री, उतनी दूर नहीं। सिर्फ तुम्हारी अपनी बहनों में और तुम्हारी मदर में, अगर क्या तुम्हारी दादी की तरफ अगर ऐसा कोई तुम्हारी अगर ऐसी कोई कहानी है जिसमें कि किसी को कैंसर की हिस्ट्री है या फिर किसी का रक्तचाप का प्रॉब्लम है या किसी का खून गाढ़ा होता था, सिर्फ उसी केसेस में मैं ये दवाई नहीं दूंगी।
नहीं, हमारे परिवार में सब तंदुरुस्त है मैडम।
और तुम तो अभी किसी चीज़ की दवाई तो नहीं खा रही हो, जैसे कि टीबी या मिर्गी की कोई दवाई खा रही हो? क्योंकि उन दवाइयों के साथ मैं ये दवाई नहीं दे पाऊंगी।
नहीं मैडम, हमारे तो दोनों बच्चा भी नॉर्मल डिलीवरी हुआ है।
बहुत ही बढ़िया, बहुत ही बढ़िया। तो बताओ फिर अभी कौन सी चीज़ का तुम इस्तेमाल करना चाहोगी?
ये गोली ही ठीक लग रहा है हमको। ये गोली हमारे गांव में कहाँ से मिलेगा मैडम जी?
तुम्हारे गांव में आराम से जो भी सब सेंटर है वहाँ पे आशा वर्कर रहती हैं। आशा वर्कर से एक बार मिलोगी, उनको एक बार ये दवाई के बारे में बताओगी, वो तुम्हें खुद से ये दवाई निःशुल्क दे देंगी।
मैडम गोली ही ठीक लग रहा है,
आप
गोली ही दे दीजिए।
हमको गोली एक का दे दीजिए ना। हम
बिल्कुल,
लेके दे देंगे।
मैं तुम्हें अभी अगली 3 महीने की दवाई यहीं से दे देती हूँ, और इसके बीच में जाकर तुम अपने सब सेंटर में जाकर एक बार आशा वर्कर को मिल लेना, उनको दवाई दिखा देना, वो तुम्हें दवाई निःशुल्क दे देंगे। अगर पैसा भी खर्चना पड़ा तो 5 रुपए से कम में दवाई तुम्हें मिल जाएगी।
जी मैडम, बढ़िया, ये अच्छा उपाय है।
अपने गांव के आसपास के लोगों को भी बताना कि आके, जैसे तुमने समझदारी का काम किया है, वो लोग भी आके इसके बारे में जाने।
वो रमेश बाबू पूछ ही रहे थे। ठीक है मैडम,
धन्यवाद,
बहुत बहुत धन्यवाद आपका।
Good morning, doctor.
Good morning. Good morning, Madhu. How are you?
I'm good, ma'am.
And how is the little one doing?
Both are fine.
Have a seat, please.
Thank you, ma'am.
आज कैसे आना हुआ मधु?
We have come to you for the advice of contraception, as we don't want any pregnancy for at least next 2 years.
So I believe Madhu, you're working, right?
Yes, ma'am.
Okay. So how do you intend to feed the baby?
Ma'am, I, like all mothers, I also intend to breastfeed my baby exclusively. I have heard about the benefits of exclusive breastfeeding. Then, doctor, what are the other methods which are safe during breastfeeding? Please guide us.
Okay. So first I would like to tell you about pills.
Pills are hormonal, ma'am. Aren't they affect the breast milk production or maybe?
Yes, Naveen, your concern is absolutely genuine. Basically, pills do contain element of hormone, and the pills that I am prescribing for Madhu, basically they are safe during the breastfeeding period. So there are two different type of pills in the market mainly. One it contains progesterone and estrogen both, and one contains purely progesterone. So I will be prescribing her progesterone only pills, which are absolutely safe during breastfeeding, and they do not hamper the amount of milk production. Your compliance will determine how effective this method of contraception will be.
And ma'am, side effects of these pills?
Like any other drug, Madhu, some amount of side effects are common. So you might experience irregular bleeding, headache, nausea, or slight amount of breast discomfort. But if it is hampering your routine activities, I will definitely help you out with some other method. But some amount of discomfort will definitely be there for the initial few weeks.
I don't think, ma'am, it will help her because she might get forget to take pills daily in the same time.
Okay.
So, are there any other methods of contraception?
Okay. So, if we do not opt for progesterone only pills, then we can talk a little about copper T insertion.
Copper T.
Have you heard about copper T?
Yes, ma'am. My sister was inserted copper T after her delivery.
Okay.
But she complained a lot of discomfort, heavy bleeding, irregular bleeding, and lot of inconvenience. So.
Okay. So basically, Madhu, copper T has a lot of myths attached to it. Most of the patients like you are very apprehensive about copper T use. But if it is inserted at the right time, so basically there are two types of copper T mainly in the market. So one is this copper T 380, which is effective for 10 years. And one is this copper T 375, it is effective for 5 years. Like in your case, you told that your baby is around 2 to 3 months old right now, will be a good choice in your case. Now, I will just show you, this is just a model of your uterus. So this is the uterus and this copper T I have inserted inside. So this is copper T 375.
Ma'am, as you said, it will be in the uterine cavity. But will I be able to conceive again if we plan for another baby?
Definitely. So the good point about this method of contraception is that there is rapid return of fertility. Like today, if you remove, you can expect to conceive in another few months.
Okay. Ma'am, are there any side effect of this contraception?
Again, this method also has some side effects. There may be initial heavy menstrual bleeding. So you may have heavy periods for initial 2 to 3 months, like she told her sister has been experiencing. Yeah. But that is because the device will take at least this much time to adjust. So after 2 to 3 months, the symptoms will subside. And even if they don't, you can always seek a follow-up advice with me.
Is it 100% effective, ma'am?
No, Naveen, no method is 100% effective. So again, with this also there is chance of failure. But the chance of failure is very less. It is around 99% safe. So would you like to get copper T inserted?
We think that this option is better for us.
Even I feel, Madhu, for the kind of work that you are doing and with a small baby, you should opt for copper T. And whenever you need to plan for the next pregnancy, 2 years or 3 years down the line, I will get it removed. So if you're ready, I'll just take a consent, Naveen. I'll just take some signatures of Madhu and yours. And since she has come today, might not come later. So let us get the copper T inserted today itself.
Yes, doctor.
Okay. Thank you.
Good morning, doctor.
Good morning, ma'am. Please have a seat.
So, what's your name, ma'am?
Doctor, I'm Sara.
Okay. Hello, Sarah, ma'am. And how old are you, ma'am?
I'm 22 years old.
22. And what do you do, ma'am?
I'm second year BSc.
Oh, that's so nice to hear, ma'am. Chalo. Anyways, can you let me know what brings you here, ma'am?
Doctor, I'm looking for contraception for myself. No, doctor, I'm not married.
Acha. So, you're unmarried.
Yes, doctor.
Okay. Nice. So, how can I help you in contraception?
Doctor, I've read lot of stuff online,
Okay.
but I'm not able to choose any contraceptive method for my lifestyle.
Well, I must appreciate the fact that you have come here seeking contraception, because at any point of time, seeking contraception is always far better than landing into unwanted pregnancy.
Doctor, I'm not in a permanent relationship with anybody. So I'm looking for a short-term method, probably.
Okay. So, ma'am, for short-term contraception, I would like to suggest you should go for barrier contraception.
Barrier, I do not understand that term. Could you please break it in a simpler word for me?
Okay, let me elaborate. Now, barrier contraception are the methods in which we use some devices or something that prevents the entry of the sperm into the female genital tract. Now, you might have heard about condoms, male condoms.
Yes, doctor. I know about
Okay.
them.
Now, on the same lines of male condoms, we have female condoms, okay, which are known by the brand name Femidom or Femishield. Now, you can very well use these condoms, and definitely these will act as a barrier method and will definitely help you in your contraception journey.
Doctor, I've also heard about pills. A lot of my friends are taking these pills. So, what is your take over them for me?
See, pills are also a good option for you, but I must say, pills, if you start taking, then you have to take it on a particular time of the day. They have to be continuously taken for over 21 days, then they have to be stopped, and once you have your periods, it has to be started again. But looking at your scenario and at your age, I would suggest that you should go for barrier contraceptive methods rather than taking pills. And definitely pills are better for couples who are already married, who are seeking contraception, who are willing to space their pregnancies.
Okay, doctor. So, pills, condoms. Do we have anything new, doctor?
Like I'll tell you, in this barrier contraceptive methods, the female condom that you will be using, you have to use this condom like prior to your sexual activity. You have to take this condom, insert into your vagina, and you can have the coitus, and post coitus you can keep it for 3-4 hours and you can take it down. Similarly, on the lines of barrier contraception, the Nuva rings.
And how successful is this Nuva ring?
See, Nuva ring has got a very high successful rate, but not necessarily the barrier contraception that I am talking about. The female condoms, they have also a very high successful pregnancy control rates or contraception rates. Now, when these barrier contraceptive methods like condoms are used simultaneously or in adjunct with these spermicidal jellies or spermicidal foams, the success rate of this method increases drastically better. And you know, one point which I would like to tell, now not only they offer contraception, they also offer a lot of other benefits like preventing sexually transmitted infections. Sexually transmitted infections like syphilis, like chlamydia, like this herpes, like you have this cervical cancer. They also offer a great role in preventing sexually transmitted infections.
Okay, doctor. And doctor, I have also heard about certain vaccinations that one of my friend got. So could you tell me about that?
Yes, there are also vaccines available for some sexually transmitted infections, which is human papilloma virus, which causes this cervical cancer. Now in market there are 2 vaccines available for cervical cancer. One is a Cervavac and one is a Gardasil. Now since you are or females of your age are into multiple sexual partners, and as such, if included with cervical cancer vaccines, they offer a great relief.
Okay, doctor.
Anything else that I can help you with?
Thank you, doctor. I think I'm quite satisfied with the
choice of options that you have given me, and condoms provide all my needs. They cater to all my needs. Thank you, doctor.
Thank you so much, ma'am. Have a nice day.
डॉक्टर साहब नमस्ते।
अरे नमस्ते नमस्ते
नमस्ते,
नमस्ते।
डॉक्टर साहब।
प्लीज 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 बैठिए बैठिए।
Thank you.
बैठिए। बताइए कैसे आना हुआ, मैं क्या मदद कर सकता हूँ आपकी?
डॉक्टर साहब, मैं पिछले कुछ महीनों से बहुत परेशान हूँ अपनी ब्लीडिंग को लेके। मुझे बहुत ज़्यादा ब्लीडिंग हो रही है, जिसकी वजह से बहुत थकान और कमज़ोरी आती जा रही है। क्या आप इसके लिए मुझे कोई उपाय बता सकते हैं?
अच्छा, मैं पूर्ण सहायता करना चाहूँगा आपकी, लेकिन उससे पहले मेरे कुछ सवाल हैं, ठीक है? तो क्या मैं जान सकता हूँ आपकी उम्र कितनी है?
मेरी उम्र 40 साल है।
अच्छा, और शादी को कितना टाइम हो गया आपका?
शादी को
7 साल हो गए।
अच्छा, आपके बच्चे कितने हैं?
मेरे 2 बच्चे हैं डॉक्टर साहब।
अच्छा, छोटे बच्चे की उम्र कितनी है आपकी?
छोटे बच्चे की उम्र लगभग 4 साल।
अच्छा, लगभग 4 साल है। तो अच्छा एक बात बताइए, ये आप जो बता रहे हैं ब्लीडिंग की समस्या, अधिक मात्रा में रक्तस्राव होना या थकावट होना, ये कब से हो रहा है आपको?
ये मुझे डॉक्टर साहब लगभग पिछले 7-8 महीनों से हो रहा है, ब्लीडिंग की समस्या।
अच्छा, तो इससे पहले आपका मासिक धर्म सही टाइम से आता था?
जी हाँ डॉक्टर साहब, इसके पहले बिल्कुल नियमित रूप से आता था।
नियमित रूप से आता था। और उससे पहले मतलब ब्लीडिंग का मतलब ये कैसा था कि बहुत ज़्यादा ब्लीडिंग होना या कम ब्लीडिंग होना या गांठें आना, ऐसी कोई समस्या थी आपकी?
जी नहीं डॉक्टर साहब, ऐसी कोई समस्या नहीं थी।
अच्छा।
ब्लीडिंग ज़्यादा आती थी, टाइम से आती थी और ठीक ठाक आती थी।
तो इन पिछले 7 महीनों में आपको बहुत ज़्यादा ब्लीडिंग हो रही है?
जी डॉक्टर साहब।
ठीक है ठीक है।
डॉक्टर साहब इस उम्र तक आते ब्लीडिंग तो बहुत ही साधारण सी बात है, होती रहती है। हम यहाँ पर मेनली आए थे कि हमें कुछ परिवार नियोजन उपायों के आप बारे में बताएं, क्योंकि हमारे 2 बच्चे हो गए, हमें आगे बच्चे नहीं चाहिए। तो कुछ परिवार नियोजन उपाय साधन के बारे में आप बताएं तो ज़्यादा ठीक होगा।
अच्छा ठीक है, मैं समझ सकता हूँ आपकी परेशानी। 2 परेशानी है, एक तो परिवार नियोजन और अधिक मात्रा में रक्तस्राव। देखिए, मेरे पास आपके इस समस्या का एक बहुत ही अच्छा हल है। एक चीज है जिसे हम कहते हैं मिरेना। दिखाता हूं मैं आपको। इसे कहते हैं मिरेना। इस वाले यंत्र को अगर हम आपके गर्भाशय में डाल दें तो इससे क्या होता है, आपका जो मासिक धर्म ये समय अनुसार धीरे 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 बंद हो जाता है। आपके ब्लीडिंग की समस्या बंद हो जाती है और आपको परिवार नियोजन का भी एक उपाय मिलता है, जिससे कि आपको फिर बच्चा नहीं हो सकता है। ठीक है, तो ये आपके लिए बहुत ही अच्छा उपाय है।
डॉक्टर साहब, लेकिन ये तो मुझे ऐसा लगता है कि कुछ ऐसा एक प्रॉपर्टी जैसा भी दिखता है ये।
देखिए,
अरे आपकी भाभी को डला था ना?
भाभी जी ने लगवाया था, उनको बहुत ब्लीडिंग हुआ था, निकलवाना पड़ा उनको।
बहुत दर्द
ये
रहता
हम नहीं
था।
लगवाएंगे डॉक्टर साहब, इससे तो मुझे लग रहा है कि मेरी समस्या ठीक नहीं होगी।
मैं आपकी बात समझ सकता हूँ, ठीक है। ये दिखने में कॉपर्टी जैसा ही दिखता है, लेकिन ये कॉपर्टी है नहीं।
डॉक्टर साहब हम ऐसा ना करते कि हम बच्चेदानी ही निकलवा दें, क्योंकि 2 बच्चे हमारे हो चुके हैं, हमें आगे और बच्चा चाहिए नहीं। तो परिवार नियोजन वाला काम भी हो जाएगा और साथ में जो इनकी परेशानी है कि इनका मासिक धर्म ज़्यादा आता है तो वो भी ठीक हो जाएगा, दोनों ही काम हो जाएंगे। तो बच्चेदानी ही निकाल दीजिए ना डॉक्टर साहब।
हाँ डॉक्टर साहब, ये
वो ज़्यादा सही नहीं रहेगा।
सही बोल रहे हैं ये।
देखिए, मैं आपकी बात पूरी तरह समझ सकता हूँ, लेकिन हर किसी इलाज का एक तौर तरीका होता है। जैसे कि आपके केस में आपको परिवार नियोजन भी चाहिए, आपको मासिक का भी परेशानी है, तो इसमें जब हम इलाज शुरू करते हैं, हम एक तय किए हुए तौर तरीके से इलाज शुरू करते हैं। जैसे कि पहले दवाइयाँ देना जिससे कि आपका ब्लीडिंग कम हो जाए, जैसे कि और कुछ दवाइयाँ देना जो आप खा सकते हैं जिससे कि आपका साइकिल थोड़ा कम हो जाए, या जब इन दोनों में से कोई भी आपको करने के बाद छुटकारा ना मिला तब ऑपरेशन किया जाता है। हालांकि ऑपरेशन के अपने नुकसान भी हैं, जैसे कि अगर समय से पहले मैंने आपके गर्भाशय को ऑपरेट करके निकाल लिया तो चांसेस ये भी रहते हैं कि आपको समय से पहले बुढ़ापा आ जाना, हड्डियां कमज़ोर हो जाना और ज़्यादा थकावट लगना, ये सब जैसी चीज़ें। और वैसे भी आपको पता है ऑपरेशन के जो हानि होते हैं। आपको एक दिन हॉस्पिटल में रहना पड़ सकता है, 3 या 4 दिन हॉस्पिटल में रहना पड़ सकता है, इन्फेक्शन के चांसेस बढ़ जाते हैं। तो जब हमारे पास सारे साधन फेल हो जाते हैं तब ही हम ऑपरेशन की बात सोचते हैं। लेकिन आपके केस में मैं बता रहा हूँ, मिरेना सबसे वंडरफुल और सबसे लाभदायक चीज है।
सब सही कह रहे हैं, हमें मिरेना ही सोचना चाहिए। तो डॉक्टर साहब, क्या हम आज ही लगवा सकते हैं इनको?
हाँ जी, जरूरी। ऐसा नहीं है कि आप आज लगवा सकते हैं। हम मिरेना को जब आपका मासिक धर्म आता है उसके दूसरे या तीसरे दिन में ही लगवाते हैं। लेकिन इससे पहले कुछ चीज़ें हमको करनी पड़ती है, जैसे कि आपकी सहमति लेनी पड़ती है और एक छोटे से टुकड़े की जांच भी करनी पड़ती है। इससे अगर आप लगाएं तो आपको और भी फायदा है। कुछ कैंसर से भी आपको मुक्ति मिल सकती है, जैसे गर्भाशय का कैंसर। जब भी मिरेना हम लोग इस्तेमाल करते हैं, ये गर्भाशय का जो परत है उसको भी ये कम करता है, सो दैट गर्भाशय का जो कैंसर है वो भी कम हो जाता है। और हम इसको जब आपके गर्भाशय में लगाएंगे उससे पहले एक छोटा सा टुकड़ा लेंगे और उसी सेटिंग में हम मिरेना इंसर्ट कर देंगे। ठीक है?
डॉक्टर साहब, मुझे लगता है कि ये सही उपाय है। मेरे को तो एक लग रहा था कि कैंसर की भी शिकायत है, लेकिन अभी वो भी क्लियर हो गया डाउट। तो हमको मिरेना ही लगवाना चाहिए। बहुत बहुत धन्यवाद डॉक्टर साहब।
थैंक यू डॉक्टर साहब, थैंक यू सो मच।
समस्या का हल मिल गया आपका।
बहुत बहुत शुक्रिया, बहुत बहुत शुक्रिया। नमस्ते।
All right. So this was the wonderful role play. May I please invite Colonel Sirisha ma'am and Dr. Professor Rachna Chaudhary madam to give their valuable feedback. You have to unmute yourself, ma'am.
Okay. This was a wonderfully enacted role play session by the postgraduates, and we all know that role play is an important teaching method used in ATCOM, and it not only improves the communication skills, but it also focuses on empathy. That was the main purpose of introducing ATCOM, attitude and communication skills. Now, in both the videos, there is a gather approach for contraceptives, which means greet, ask, tell, help. So all of them, they were followed very nicely. And this scenario-based learning means the role play, what the students did. Typically, role play may you give a scenario and then they have to enact. Some of the students will become doctors, some of them will become patients or a paramedical staff. So they will, and there is no script. So that is the beauty of it. They will have spontaneous interaction as well as decision making. Plus, it is also helping in empathy, skill development, and then their communication skills, cognitive and affective skills, in the long run, they will be improved drastically.
Yes, ma'am. Would also like to welcome Dr. Lakshmi Srikhand ma'am, who has joined us, Durga Prasad sir, Anita Rajoria ma'am, and Achla Batra ma'am. Thank you so much for joining us.
Yes.
Sirisha ma'am, maybe she was having some problem with the audio.
What happened? They cannot comment. Okay.
Lakshmi Srikhand ma'am, if you would like to say something.
Dr. Lakshmi.
Sirisha ma'am is here.
Yeah. She's come. You have to unmute. No, we are not able to listen to you.
To unmute.
You unmute from, yeah.
Ma'am, it seems there is some audio issue with ma'am.
Audio issue. Okay. Yeah. Okay.
Maybe we'll have a ma'am's comment a little while later.
Later. Let us move to the second role play.
Yes, madam.
Yeah. So our second role play is on confidentiality and when it might be breached. So I welcome Dr. Pratnya Changede. Can I have? Yes. Who is a professor, Department of Obstetrics and Gynecology in LTMMC. First Joint Assistant Editor, Journal of Obstetrics and Gynecology of India. Member Management of OXY. and MUHS recognized postgraduate and undergraduate teacher, recipient of several awards. And also I welcome our Professor Sheila Mane, who is our next ICOG chairperson, and she had many credentials with her. At present, she works in KC General Hospital as a senior consultant, and she has adored the post of chairperson Safe Motherhood Committee Foxy as well.
Hello.
So welcome, Dr. Sheila. Welcome, Dr. Sheila.
Yeah, thank you. Yeah.
And now we are at the second role play, that is on confidentiality and how it affects and how when it might be breached. So shall we start our role play? I welcome the participants here, Dr. Rajani Kadam, Marilyn Vincent, Dr. Akar Prabhu, Dr. Apra Negi, Dr. Vidhi Fora, Dr. Totini Sarkar, Dr. Harsha Sankle, and Dr. Kirtiga. Hope they are in the audience also. Let us start the role play.
Yes, yeah, please. Yeah.
Hello everyone, I am Dr. Pradnya Changede, Professor Additional, Department of Obstetrics and Gynecology, Lokmanya Tilak Municipal Medical College and General Hospital, Sion, Mumbai. Today, the residents of our Department of Obstetrics and Gynecology will be presenting a role play for you. The role play is based on confidentiality and when it can be breached in obstetrics and gynecology. We are enacting a play in which an antenatal patient has tested positive for retroviral disease during routine antenatal visit. We are enacting how the doctor reveals this diagnosis to the patient and her partner, and how and when it can be confidentiality can be breached to the other healthcare workers, and in which scenarios the partner may not be informed about the pregnant wife's status. We have taken the guidance of HIV Act 2017 for this. Thank you so much. Hope you enjoy watching this. Thank you.
Scene 1. The antenatal OPD where the junior doctor interacts with the patient.
Doctor, good morning, doctor. Oh, good morning. We'll need to know some of your basic investigations today, including blood sampling. We'll get the reports by tomorrow.
Can you tell me what investigations to be done, doctor?
Just the usual antenatal test. We'll get the reports by tomorrow and we'll discuss it by then. Sister, can you do the blood sampling for this patient?
Show your hand, Mrs. Anita. Nurse, what test you are taking?
The same test which the doctor said to you.
But they didn't mention. Oh.
Scene 1 ends. This scene shows what not should be done in a clinical practice. This is where there was no pre-test counseling done for the patient. Scene 2. The ward rounds. After the test results have arrived.
Mrs. Anita, your reports have arrived and I see one of them is HIV positive.
Oh, I didn't know that you have sent my sample for an HIV test.
Oh, I'm sorry, I forgot to mention it yesterday. But as per hospital protocol, we send all these investigations for antenatal checkup routinely.
How can my wife be HIV positive and I am HIV negative? There must be something wrong with the report.
Yes, this must be wrong. Please check again, doctor.
Mrs. Anita, please calm down. This report cannot be wrong. Sister, this patient is HIV positive. Please shift her to the HIV bed.
Come on, Mrs. Anita. This is your bed. Please get shifted there.
What is happening here? Why is that patient is being shifted? Good morning, ma'am. Ma'am, the patient is HIV positive, so I asked the sister to shift her to the HIV bed.
Doctor, that's serious breach of confidentiality. You cannot reveal such matters in a public setting and certainly not without patient consent. And how can you label that bed as HIV positive? In such situations, you have to follow universal precautions. It is for your and our own benefits. Mrs. Anita, can I please talk to you privately?
Yes, ma'am.
Ma'am, please wait outside for a few minutes.
Yes, doctor.
This scene shows what exactly should not be done in clinical practice. This example was how the confidentiality of the patient was broken and the whole world knew about the HIV status of the patient. This leads to distress in the patient. In the ANC OPD, this scene shows what actually should be done in the clinical practice and how the senior doctor interacts with the patient.
Good morning, Mrs. Anita. How are you feeling today?
I'm fine, doctor. I came for a routine checkup.
Okay, as a part of your routine antenatal investigations, we'll be sending some of your blood samples today for hemoglobin, blood group, and also to screen infections like hepatitis B, HIV, and syphilis.
HIV test. Is it compulsory, doctor?
Don't worry, Mrs. Anita. It's not compulsory, but we recommend the test because it allows us for early detection and prevention of mother-to-child transmission. But if you still don't want the test, you can opt out from it. It will not affect your rest of the care.
Doctor, will anyone know about my result?
No, don't worry, Mrs. Anita. It is strictly confidential. Without your consent, we'll not tell anyone about the test. Nurse, please collect her samples. The samples will be sent to Integrated Counseling and Testing Center. Doctor, please take her consent before collecting the samples.
Sign the form, Mrs. Anita.
The next day in the ANC OPD, the HIV test results have come positive.
Good morning, Mrs. Anita. How are you feeling today?
I'm fine, doctor, but I'm worried about my blood test reports.
Don't worry, Mrs. Anita. I'll share your results very sensitively, and it will all be very confidential. Are you comfortable to proceed?
Yes, doctor. Please tell about the reports.
The report here shows that you are HIV positive. I know this is a very difficult news, but please remember, with treatment, you and your baby can lead a healthy life.
HIV positive. Oh my God. What will happen to my baby? What the baby if gets affected by HIV test? What about my husband?
Don't worry, Mrs. Anita. I hear your fears, but you have to understand that by telling your HIV positive status to your husband, it leads us to screen him early and start treatment in case he is positive too. And if you are not comfortable with it, may I ask you that regarding your positive status, will he turn violent towards you or may cause harm to you in any case possible?
I'm not sure, doctor. I will give it a thought.
Okay. Don't worry, we have good counselors here who can navigate you through the process.
Don't worry, Mrs. Anita. I'm here to help you in any way possible.
Also, doctor, these investigations will be paid by my office through an insurance company. And will it be disclosed to them? And if it's so, I will lose my job.
No, Mrs. Anita. Without your consent, we will not disclose any information to anyone. And anyways, there is no grounds for you to lose your job, even if you are HIV positive.
Okay, doctor.
Good morning, doctor. May I join? I also want to know my wife's HIV report.
Good morning, sir. I am discussing some sensitive matters with your wife here. I'll call you in a few minutes with her permission.
Please, doctor, please don't tell her.
You may wait outside. I'll call you.
Oh, okay.
See, Mrs. Anita, how this creates a difficult situation. I would recommend you telling your husband in case he is positive. This will let us screen him early and start the treatment.
Okay, don't worry, Mrs. Anita. You're not alone. We can together talk to your husband and safely disclose this test results. We can also screen him early so that he can get the treatment if needed.
Okay, doctor.
Thank you, Mrs. Anita.
Ma'am, why didn't you disclose the information to the husband? Aren't we supposed to inform anybody at the risk of contracting it?
That's a very good question, doctor. A counselor or a healthcare provider who is in direct contact of the patient's well-being can disclose the HIV positive status to her partner. But in cases where there is an apprehension that the partner may turn violent towards her, we may choose not to disclose the information.
Ma'am, will the healthcare provider be penalized for sharing this information? And what about the baby? Can we share it with the neonatologist?
So the Act of HIV 2017 protects healthcare workers and will not be liable for any criminal or civil action. And regarding neonatologist, I think we should definitely tell the neonatologist because he is in direct contact for the baby's well-being. Does that make any sense?
Oh, I see. Yes, that makes sense. Thank you, ma'am.
The scene ends. This scene shows what exactly should be done in the clinical practice and how breaching confidentiality is not right and how pre-test and post-test counseling are of utmost importance in these cases. Lastly, Mrs. Anita was given ART. She delivered the baby. The baby was also given ART and the baby was in.
Thank you.
Thank you.
Thank you.
Thank you.
Ma'am, 1 second. Huh?
I think the last part did not display, no?
Yes,
Ma'am, we have a PPT. Could you please show the HIV PPT? And I
Yeah. Because the last, I think,
मैम
few
वो
take
प्ले
home
कर रही हूँ
message.
मैं वो फिर से प्ले कर रही हूँ
हाँ, please play. Great.
just show the HIV PPT, and I invite Dr. Meryl Vincent, who is a senior resident at Lokmanya Tilak Hospital, and Dr. Vidhi, who is a junior resident and one of the participants of the video. They shall throw some light on HIV Act. Yeah. Shreya, yes.
Yeah. But we are not able to. She's, yes, take one point.
Dr. Meryl?
Dr. Meryl is there?
Yes, she is there. Please make her the co-host.
Ma'am, she is already posed.
Okay. Dr. Meryl, over to you.
शेयर स्लाइड शो कर दीजिए मैम उनके एंड से शो किया है स्लाइड
अच्छा, ओके ठीक है, make it slideshow and present.
मेरिल मैम
It's all right. Just typing something. They are saying that they are speaking, but we can't hear them. No. Can you see if you can unmute them, Shreya? Dr. Meryl?
मैम ऑलरेडी अनम्यूट है मैम मैम हेलो मैम
Yes.
मैम उनके यहाँ से ऑडियो में भी इशू आ रहा है
All right. We'll take this again. In the meanwhile, we have Colonel Sirisha Madam from AFMC Pune.
Hello.
Yes, hello.
Yeah.
Hello, ma'am. Good afternoon.
Good afternoon. No, your voice is echoing.
Yeah. Just a minute. Just a minute.
I'm logging with the two devices, ma'am.
Yeah,
okay
she has
now?
logged in one. You close it.
Yeah.
Then you close it.
Yeah. Am I audible now?
Yes, ma'am.
Yes, you are audible.
Yeah. Firstly, I would like to thank all of you for giving us this opportunity to do this role play. Initially, we thought it would be a big headache, but then all our residents also enjoyed thoroughly while doing this. And I hope we have brought out all the important aspects which have to be kept in mind while communicating with the patient. That is, most importantly, making them understand that we have understood what they want to tell us, right? And also that we have to be very patient in listening to what are the complaints. However, close we are to getting annoyed about their suggestion of doing a hysterectomy for a situation like me, they can understand. thing is any unmarried lady or any lady in young age, whoever comes for contraception or any other requirement, we should definitely try to sensitize them about the need for HPV vaccination and the need for barrier contraceptives, especially if it is an unmarried lady. Yeah, I hope all of you enjoyed the role play. We have taken 4 different situations, 2 in Hindi, 2 in English, trying to depict the average population of our country, and all 4 of them with a different set of problems, with a different set of solutions and treatment for them. Yeah.
Yes, it was a great role play, I must say, and it has included every aspect of meet, greet, and as well as explaining every aspect of contraception. Congratulations and thank you. Any questions from the audience also, you will be able to answer. Thank you very much. Thank you very much. Yeah.
So I think
Dr. Sheila's comments, yes.
Yeah, I think as they rightly said that they have taken the Government of India guidelines and accordingly they conducted. So, which is very important. And I think now whenever we are talking about a HIV positive patient, we don't say that. We say patient living pill.
It's stuck.
Yes, it is stuck. It is
Hello.
stuck.
Yeah. So we call them as PLHA. Okay, that is people living with HIV and AIDS. So what happens? Nobody will know. Even somewhere in the corner also we can write that. So whenever she comes to the OPD or any time, no. So we are not revealing to anybody, and her confidentiality is maintained. So that is very important. And the counseling part also dealt very well, because disclosing it to the husband, it is a very good thing that you tell the patient only that she should only disclose it to the husband, because we don't know how they take it and how much time she can take. But very important thing was suggested was that the treatment should be started immediately, because that is very important, because she is pregnant also. So all of us, we know that as early as possible, the treatment need to be started. And one practice they showed for the first time where like the confidentiality was not maintained. And one more thing we have to learn is like we have to take a consent of the patient, or at least inform her that we are going to do these tests. It is not like, even though it is a Government of India recommendation that uniformly we have to do it all, which is not there in other countries, but it is good to tell the patient that it is required and we are going to do these tests. So I think all those points were brought out very neatly and carefully. And all of us, we know that we don't have to segregate them, and what is required is the uniform. We have to follow all the protocols.
Universal
Uniform.
precaution.
Universal precautions need to be taken for each and every patient, which is not happening. So I think that is very important, because sometimes I also work in a public sector, we get the patient who walks in, and there is no time to do the test also. So we have the card test available in the labor room. So if the reports are not available for the safety purpose and to know, we do the card test as an emergency. So as soon as the patient comes, if we do, by chance, if we do not have the reports, at least we will get the report immediately. So that is the another way to detect, because sometimes if we get a patient who is unbooked and then, okay, so, and in cases where we really have a doubt, I think we need some senior should come, and they should come and talk to them. Yes, now the ART centers are always there, okay, and the ART center people are very good in counseling. So once we get the result, it is positive, we send them to ART center, and I have seen them. I mean, they have the separate chambers where they sit with them and they do the counseling. I think we would also like to listen from Dr. Pragnya. Yeah.
Yeah. So, good evening, everyone. Sorry, I'm traveling, so I have joined late. First of all, let me thank Dr. Ashok Kumar sir,
Dr. Parag Binewale sir, ICOG, Foxy for giving the residents an opportunity to do this role play on this very important topic of confidentiality in obstetrics, and when can we really break it and how we should be maintaining it. We really like the topic that we were given of HIV in pregnancy, which is a very common scenario in the OPD, how to deal with, testing these patients. And as Dr. Sheila Mane madam said that, counseling these patients for pre-test, not discriminating with them in the OPD, even after the patient is positive. Most of the times when you ask only certain husbands to get tested, that also discriminates. We should voluntarily ask all the husbands also to test for HIV. Then how to break the news to the patient, how to encourage the patient to disclose to the partner about the HIV status. And of course, the most important thing is regular ART for the mother, as well as giving ART prophylaxis to the neonate, which helps a long way. And of course, partner screening is very important. Very important here is the HIV Act of 2017, which gives certain benefits to the woman who is infected with HIV. So although we encourage the mother to disclose to the father about the HIV, if she is positive, there are certain exceptions which are given in the act. That is, if she feels that there will be violence against her, whether she will be abandoned, whether any physical, mental harm, abuse will happen to her previous children or the unborn child, then she may not choose not to disclose the HIV status to the partner. So it is very important that you should gauge about the anger issues of the husband, as we have tried to ask her whether she feels what reaction would her husband gives if he knows that she is HIV positive, and she should not be left in a pregnant state, abandoned, or having some physical or mental violence. So specific provision is made in this act to protect the females. And of course, we can disclose to the treating neonatologists, the other healthcare workers. And very important here is most of the times, rather than, put labels of an HIV bed or, HIV positive or seropositive, we practice universal precautions. I think universal precautions is where you treat every body fluid as to be potentially contaminated with HIV or other infections, and we should have all hygiene practices, wear gloves, wear PPE kits. Whenever you come in contact with direct body fluids or blood, we should really protect ourselves. So I hope you all enjoyed the role play done by the residents. They have actually worked very hard. In spite of their busy schedules, all the residents have come together and put up this role play. And we are thankful to ICOG Foxy for giving us this opportunity to put together this role play. And I hope it is beneficial to all the students.
Yeah. And
Yeah.
thank you from my side also, even though I'm a part of ICOG. I would like to thank Dr. Ashok Kumar and Dr. Vidya for taking up this initiative, okay, of Odyssey, like which we have started. And I think it is really a learning session for all of us also.
Yes.
And that ATCOM, I think, which is very important, which is newly introduced to undergraduate students, that is the communication skills, which is a very, very important thing. In fact, as I'm going to take over as chair, Vandana is here. Vandana, I was just thinking that whether I can talk to the DNB, NB people and to see that this, whether we can again think about it, ATCOM module and all that. Okay.
No,
So we
will have these communication skills in your tenure also. ATCOM models.
Yeah. Yes, we'll continue.
What
And
should be
NB
done,
people,
what should not be done. Yes.
NB teachers, if we can involve.
Yes.
Because they are not medical college teachers, so they may not have exposure. So we can do it for NBE teachers, and as Dr. Vidya knows, we have many in Karnataka.
Yes.
Okay. Another thing, I think one more counseling will be required just for the delegates' purpose is regarding the breastfeeding. Okay. Now, the guideline is for the low socioeconomic countries. They say not to stop the breastfeeding. But again, there, I think we will have to counsel the patient regarding the breastfeeding in case if happens to be that she is HIV positive. And in a rare scenario, very rare scenario, which we have come across, we have seen that, yeah, you have to, I mean, the wife was positive, but the husband was negative, and there also required a lot of counseling. So there are different scenarios in the society. But whatever are the common, like the antenatal one, which we face regularly, is being done very well. And I really congratulate all the staff, those who have done this and taken this initiative. And thank you, Dr. Vandana and Dr. Vidya, for this initiative.
Thank you. Thank you for joining. Thank you, Pradnya, and thank you, Sheila. It
In
is
fact,
really,
I really
yeah.
appreciate this is a good way to teach the students. If you take formative lectures, maybe they don't assimilate this knowledge or feel it is boring, but it is
And
fun.
I think in this role play, Pradnya, what should not be done is also shown, which is wrong, which is
Yeah.
right. That
What is
very
right and
important.
what is wrong? Yes, that is very
Thank
good.
you so much, ma'am. Thank you for the
Thank you
appreciation.
very much. Thank you. Thank
Last,
you.
I would like to say thank you to our
Thank you,
educator,
Pragya.
Dr. Arun Nayak, sir.
Yeah,
Thank
yeah,
you.
yeah. Thank you.
Thank
Vandana, let us move for the next role play.
Yes, ma'am.
Yeah.
Shreya, please show the PowerPoint of IRA's Medical College and Career Medical Institute, Lucknow, on breaking bad news. So it's an honor to invite Professor Uma Gupta, Madam. Madam is a FIMA Fellow, Medical Education Coordinator and Head of the Department of Obstetrics and Gynecology at IRA's Lucknow Medical College. She's a Nodal Officer, RRTC, ELMC, Faculty UNESCO Chair of Haifa Bioethics with numerous administrative responsibilities. She has been awarded the Best Poster ICME, Foxy, and has over 90 publications under her name. Welcome, Madam. May I please invite Dr. Professor Aisha Ahmed, ma'am. Madam is Professor at the Career Institute of Medical Sciences and Hospital, Lucknow. Fellow Advanced Gynae Laparoscopy and Advanced Obstetric Ultrasound. She is the founder member and joint secretary of the Stillbirth Society of India. She is the editor of SBSI e-newsletter, co-editor of Pan-Asian Journal of Obstetrics and Gynecology. Her areas of interest are obstetric Doppler ultrasound, fetal growth restriction, critical care obstetrics, and decreasing preventable stillbirth. Welcome, madam.
Thank you so
Our
much.
next expert. So Dr. Professor K. Pushpalata, madam. Madam is head of the department at AIIMS Bhopal. She is the nodal officer of Establishment of Center of Excellence in Obstetric, HDU, ICU, and LDR. She is a nodal officer for IVF facility set up at AIIMS Bhopal. Member of the American Society of Clinical Oncology since 2009. She was awarded the International Development and Education Award in Palliative Care at the prestigious American Society of Clinical Oncology, Chicago, in 2014. And numerous publications are there under her name. Welcome so much, madam. Yes, Aisha, ma'am.
Thank you so much. Good evening. And thank you so much, Dr. Shok sir, Dr. Vidya ma'am, and the entire team for inviting us to take a session on breaking bad news of stillbirth. Today, we have two teams, Career Institute of Medical Sciences and ERA's Lucknow Medical College, and we'll be presenting on one of the most emotionally challenging yet essential aspects of clinical practice, breaking bad news, specifically in the context of stillbirth. So can I have my slides, please?
Shreya, please play the PowerPoint.
Yes. And make her co-host.
I would like to extend my gratitude to Dr. Uma Gupta ma'am, who mentored this session and helped me at every step. We'll explore communication strategies, psychological insights, and ethical considerations that help clinicians handle this with sensitivity and professionalism. So I would like to have the outline. The next slide, please. The next slide. Yeah, the outline. So we'll begin with an introduction to the topic, followed by a definition of what constitutes bad news. Then we'll move into practical approaches, including the SPIKES protocol, one of the most widely accepted frameworks We also show two short role plays, a poor example and a good one, to illustrate the contrast. And finally, we'll summarize key takeaways and conclusions. Next slide, please. So, starting with the introduction, next slide, please. Breaking bad news is not just a communication task. It's a test of our empathy and professionalism. It requires patience, preparation, and emotional resilience, especially in cases like stillbirth, when parents are expecting some, good news and they are so deeply vulnerable. Our tone, choice of words, and even our silences matter. It's equally important to assess how the family is reacting, their body language, their coping mechanisms, and tailor our information accordingly. So we can give you a basic outline, but then it has to vary on a case to case basis. The aim is to balance truth with compassion. Next slide, please. So, what exactly constitutes a bad news? Any news which is not welcome, which is going to adversely alter a person's life, their view of future, and it's not just the message itself, it's how it affects the listener's perception of control, choices, and hope. Next slide, please. Let's see some common barriers in the next few slides. Next slide, please. So on the healthcare givers side, we often face issues like language barriers, lack of empathy, or being rushed, especially when you have you're working in a busy government hospital, you have so many patients to attend to. So you're so rushed at times. Next slide, please. Then the environment, long waiting periods, poor infrastructure, everything can worsen the family's distress. Someone has a stillborn baby and put them in a labor room where all the expecting other mothers, they are there, or they can hear the cries of other babies. So everything can magnify perceptions. Next slide, please. Finally, we have patient-related factors. So low literacy levels, some certain cultural beliefs, fatalistic attitudes, they can all shape how the news is received. So let's start by watching a video where a team of doctors is breaking bad news of stillbirth. Please, the next slide. Next one. Yeah. Can I have the video, please?
Shreya, please play the video, the first one.
Yes, sir. Sir, she's Rani, primary gravid, 32 weeks, 6 days. Came with complaints of decreased fetal movement since 2 days. And ये हमारे पास अब आ रही हैं.
2 दिन से बच्चा नहीं घूम रहा आपका?
नहीं सर, वो मुझे लगा कि बच्चा सो रहा होगा सर. वो कभी-कभी होता है ना, कम घूमता है.
किसका बच्चा 2 दिन सोता है मैडम? किस दुनिया में हैं आप? साइमा, इन्हें प्लीज अल्ट्रासाउंड रूम में लेके जाओ.
But ultrasound room is already full.
तो बाकी पेशेंट्स को वेट कराओ, इन्हें लेके जाओ.
आप चलेंगे सर. मैडम, कुछ घबराने वाली बात तो नहीं है. वो हम बाद में देखेंगे. बच्चा तो ठीक है ना मेरा?
आप इस तरफ रुकिए, मशीन के पास कैसे आ गए? बाहर चलिए आप.
प्लीज आप बाहर आइए.
कब से बच्चा नहीं घूम रहा है आपका?
डॉक्टर, बेबी hasn't moved since 2 days.
2 दिन से बच्चा नहीं घूम रहा और आप आज आए हैं. अरे यार. साइमा, can you see there is no cardiac activity?
Yes sir, there is no cardiac activity.
See overlapping of skull bones?
Yes sir.
There is no lichen.
Yes sir.
It's an IUD.
Should I note it down sir?
Yes, note it down. And note down that it's an old IUD.
Yes
She is
sir.
very late. Already
सब ठीक है ना? आप लोग
ठीक क्या है? आप 2 दिन के बाद आए हैं. 2 दिन से आपका बच्चा नहीं घूम रहा है. बाहर रुकिए, आप बाहर बात करेंगे आपसे.
Doctor, what is happening?
बताएंगे आपको. बाहर रुकिए प्लीज.
But doctor, please come with me outside and don't cry here. And what you were doing since 2 days? Please wait outside. Doctor साहब will call you in some time.
प्लीज बाहर रुकिए आप.
कुछ तो बताइए.
बहुत पेशेंट्स हैं यहाँ पे. प्लीज बाहर रुकिए.
बहुत
चलिए
सारे मरीज हैं.
बाहर. साइमा, नेक्स्ट को बुलाओ प्लीज.
Yes sir.
आया पेशेंट भी सही रहा है.
जी सर.
ऐसे ही है. कैसे हैं आप? बैठिए जरा देखें, तो आपको भी हमने समझाया सारा। दिस इज बेबी की कोई हार्ट बीट तो है नहीं, दिस इज व्हाट वी कॉल एन आईयूडी।
सर आईयूडी क्या होता है सर?
आईयूडी के बहुत कारण है, बीपी बढ़ जाना है, कॉर्ड एंटेंगलमेंट हो जाता है। आप बस भर्ती हो जाइए, आपकी नॉर्मल डिलीवरी कराएंगे आज हम।
नॉर्मल डिलीवरी मतलब मेरा बच्चा तो अगले महीने आने वाला था ना मैम, वो पहले ही आ रहा है क्या?
देखिए सर ने आपको बताया ना, आपका बच्चा पेट में ही खत्म हो गया है।
खत्म हो गया है? ये क्या बोल रहे हैं डॉक्टर साहब?
अरे आप टेंशन मत लीजिए, हम सब मैनेज करेंगे ना, आप भर्ती होइए बस।
भर्ती क्यों बोल रहे हो? मेरा बच्चा नहीं मर सकता
अरे हम
डॉक्टर।
मैनेज करेंगे, आपको क्या चिंता है? सब मैनेज बोल रहे हैं, हमारा बच्चा मरा है, क्या बात कर रहे हैं? अरे यार साइमन ने लेके जो एडमिट करो इन्हें यार।
आप प्लीज मेरे साथ
इंडक्शन ऑफ लेबर स्टार्ट करेंगे, लेके जाइए यहाँ से।
सर इंडक्शन ऑफ लेबर कैसे स्टार्ट?
मीज़ोप्रोस्टोल दीजिए, इन्हें लेके जाइए यहाँ से।
आप मत रोने से कुछ भी बदलेगा नहीं, जो हो गया सो हो गया।
पर मैम मेरा बच्चा तो अगले महीने आने वाला था।
सब ऐसा ही कहते हैं, आप चलो।
अगला पेशेंट बुलाओ साइमा, चाय मंगवा लेना इसके बाद। हाँ लेके जाओ इन्हें।
Please come back to the PPT, Shreya.
There are a number of practical approaches to break bad news. Can you hear?
Yes, ma'am.
So, of the number of the approaches, one is spikes, ABCD, breaks, sunburn, like a number of others. But the most commonly used in breaking bad news, the spikes protocol has been widely accepted. So here, the spikes acronym S is for setting up the stage, P is for perception to know what the patient knows about herself. Invitation is about whom she wants to accompany her when the news is to be told or how much is to be told. K is for the knowledge we'll be sharing about the case. E is the emotion which you have to see at the time of breaking news and how to react. Then finally, to summarize the case, take a strategy and then plan of the treatment. Next slide, please. So when we are talking of setting up, so there should be a place which should be confidential, comfortable for sitting, give some adequate time to the patient and let her come up with the emotional problem. So privacy is one of the most important thing and there must be enough space for her accompaniments to also sit. Next slide, please. While talking to the patient, see that the eye contact is maintained. There will be situations where a good touch or to make her comfortable may also be necessary and it is accepted by the patients. Next slide, please. When you are assessing the patient's perception, first determine what she already knows about her case. Sometimes you may be a second consultant and she must already be knowing about her. Also see what is the level of her comprehension and many times you will see that patient is always in a denial mood. Next slide please. Now, obtain the patient's invitation. Sometimes your patients would not like to know the whole of the bad news. They may say that you only tell me something, or they may want someone else to accompany. As in our role play, you saw that the patients were all alone and there were no one to support her, and nothing was asked also. The patient has the right to know how much she wants to know about her at that point of time. At the same time, later on, she may again ask you questions if she wishes or if she is now prepared. So, continue to answer and keep patience. The next slide, please. At this point, you want to give her some knowledge about her case. See that all your papers, all your investigations, all information is ready at hand. Next slide, please. Next slide. Yeah. So when you are giving the information, it's always a good way to start with a warning shot. Like when you enter and you call upon, you may start with like, it has been very unfortunate. I don't have anything good, or that I have some bad news to tell you. At this point of time, it acts like a absorber, and the patient may get ready to get disclosed with the bad news. Another thing is, whenever you are talking, it should be a dialogue and not a monologue. Don't go on talking at a stretch continuously. Talk, give some information, pause, see whether it is to her level of understanding. Use the vocabulary which is of her level of understanding. Do not use technical words, medical phrases, and when you're giving information in small chunks, also take back the understanding of the patients and stop using phrases like तुम्हारे तो किस्मत में यही था, ऐसा खराब हो गया, हम इससे ज़्यादा कुछ कर नहीं सकते, nothing can be done. So such types of phrases should not be used. Next slide, please. Next slide. Next slide. When you are addressing to the emotions with empathetic responses, one of the most important thing is be ready to accept. The patient may behave in a way like she may be angry, she may be sad, she may be in a denial mode, she may be at guilt. Anticipate all these types of emotions, and it will be for you to connect with her emotions at the level in which she reacts and discuss the treatment plan to her. At this time, patient's understanding, misunderstanding, and coming to a discussion is the prime part. Next slide, please. The strategy and summary. Once the news has been broken, things have been addressed. It's a time when you take a combined approach, negotiate for the next step for the management, for the treatment, for admissions, for further tests, and be ready to acknowledge all the answers which he wants. So finally, you summarize and now you plan. And at each point, a paraphrasing is important. See that she understood and use a teach back technique, and also ask her when she is to come for follow up after her treatment, and so on. Now, we will go through a scenario in which the bad news is delivered with compassion using the spikes protocol. Yes. Dr. Vandana, please, can we have the
Yes, ma'am.
second video?
Shreya, please play the second.
Yes, ma'am.
Please call the next patient.
Yes, doctor. Patient Rani, please come in. Have a seat, please.
Hi, Mrs. Rani. I'm Dr. Sara. She is my junior resident, Dr. Mansi. How can we help you today?
Hello, doctor.
Hi.
Doctor, I'm very worried. My baby hasn't moved since 2 days.
Okay, so before moving any further, I would like to know, have you been investigated during this pregnancy, or are you coming to the doctor for the first time?
No, doctor, we didn't consult it anymore.
Okay, no problem. We'll do a scan first, okay? So, Mansi, can you please check the patient for the scan?
Yes, doctor.
Rani, would you like someone to be with you, your husband?
Yes, of course, ma'am.
Okay, sure. You can join.
Please.
Okay, Rani, I'm going to start with your scan.
Okay, doctor.
Just be relaxed. I'm going to apply some jelly. It will feel cold, okay? So don't worry. Let's start.
Doctor, baby hasn't moved since 2 days. Is everything fine?
Just don't worry. You know, during the last month, babies try and sleep a little longer. Just let me check.
Doctor, is everything all right?
Just bear with me. Let me check, please.
Doctor, please tell, is the baby moving?
Why is it
Please
taking
calm
so
down. Please calm down.
Calm down. Let me check.
Just relax, please.
Why is it taking so long? So can you see this?
What happened?
Nothing to worry. Please wait.
Okay. Rani, Mr. Raja. Now I'm done with this scan. I would like to talk with you. Rani, please just change up and meet me in my clinic. Okay? Mansi will help you. Mansi, please.
जी मैम.
Ma'am,
क्या हुआ? Nothing. आइए.
Rani ji, Raja ji, I have done the scan and seen it multiple times from different angles. I'm so sorry to say, but I can't see the heart. The baby has passed.
Nani, please don't cry. It's okay. Please.
Have some.
Nani, please don't cry. No, this can't be true. There must be a mistake. The baby was fine last week.
Have some water, please. I'm so sorry, Rani ji, this happened to you. I know this is a very hard news to have. I'm so sorry.
Doctor, did we do something wrong? Yesterday she lifted a bucket of water.
Oh no, Mr. Raja, please don't blame yourselves. Such things happen, and many times we don't even know why this happened. But in this case, we will try and investigate why this happened to you. Okay? At this stage, the first and safest option is normal vaginal delivery for Mrs. Ram. We will try and give her some pain medications to induce her labor. If you are comfortable, we can proceed with this option.
I don't know if I can bear this.
I'm so sorry, Mrs. Rani, this happened to you. I know this is an unthinkable news for you. I'm so sorry.
Doctor, will it hurt her a lot?
See, we will be with her throughout the process. We will give her pain medications, and if she wants, we can also give her epidural also. We will try to make her comfortable as much as possible.
I don't know if I can do this.
I'm so sorry, Mrs. Rani, this happened to you. Please.
Doctor, her mother is outside. Please will you call her?
Sure, we can. Nancy, just ask the sister to call you.
Sister, call Rani's mother, please.
Meanwhile, do you want to know something else?
What will be the next course of action?
See, after the delivery, we can try and send the baby as well as her placenta for the examination. This can help us know why this happened to you, and it will also help us prevent any further mishap in the next future pregnancies.
Doctor, during the procedure, will she be all right?
Physically, we will be with her through each and every step, but emotionally, it will take a heavy toll on her, and it will take some time for her to be emotionally well. We can provide you with our counselor and our care supporter also. We will be with you throughout the process. If you are comfortable, can we move forward with our admission process?
Yes.
Sure. Once, please.
Let's go back to the PPT, Shreya.
Yes, ma'am.
So we saw two videos. One was of breaking bad news in a good way, and one was breaking bad news in a bad manner. What is very important to see In both the videos, the difference is that you need to make eye contact with the patient. In the first video, we can see that the doctor is eating, the doctor is talking um, of tea, and there is no eye contact, using very technical terms like IUD and not understanding how anxious the patient or the husband is. And what makes it difficult for us is because we fear destroying the patient's hope. We fear their anticipated emotional reactions, or we are not trained in how to break bad news. There could be cultural constraints which make it harder to discuss death openly. And that's why training, debriefing, and peer support are essential for our own mental health. And a very valid point, which Dr. Sheila Maneshi has put in the chat box, the husband is not allowed inside. As per the PCPNDT in India, we're not allowing anyone besides the pregnant lady inside the ultrasound room. Although in West, we are allowing. And next slide, please. So to summarize, some do's and don'ts we've already discussed. To respect privacy, be honest, keep the language simple, and maybe instead of just saying that I can understand what you're going through, it would be better to say I cannot even understand what you're going through. Because the moment you see I can understand, sometimes you can have patients. Have you lost a baby? If you've not lost a baby, then you can't understand what I'm going through. Or to say sorry, rather than saying I'm sorry. Sorry doesn't mean that you're sorry because you've done something wrong. So I'm sorry for this situation, or I sympathize with you. So um, another thing is to allow silence, to allow tears, to accept their reactions, that their denial, to accept that. We should avoid overloading them with information. Bad news is always bad news. So if it's a stillbirth, if you go roundabout, saying, I'm not able to see the baby's heart, I don't know, let's see, let's do another scan, let's send you there, maybe, the heart rate is dropping. So at the end, it is a stillbirth for her. At the end, she'll not be having the baby. So it will always be bad news. Instead of giving any false reassurances, it is better to be honest. And empathy doesn't mean having the perfect words, it means being fully present when the family's world falls apart. Next slide, please. So, breaking bad news is not just a medical duty, it's a human responsibility. The words we choose become part of someone's lifelong memory. And very famous, quote, if we do it badly, the patients or family members may never forgive us. If we do it well, they may never forget us. So, next slide, please. I would like to conclude that patients will never care how much you know until they know how much you care. Thank you very much. And I would like to extend my gratitude to all the residents of Era Medical College and Career Institute of Medical Sciences who, despite their busy schedule, we really had to two medical colleges. So we had to do some, spacing and managing time. And thank you very much, Dr. Vanna, for all your support.
Thank you so much. It was wonderful. Pushpalata madam, we'll start with you.
Yeah, thanks a lot for having me here. I thank the organizing team. Dr. Vandana was, she was coordinating with me every day. So I really commend her commitment and engagement in this. It was wonderful interaction with her and organizers, Dr. Vidya, Madam, Dr. Ashok sir. I'm really thankful to you. And Dr. Aisha has really started off and also summed up the two videos very well. And Dr. Uma Madam has really elucidated the spike protocol in a very detailed manner. But I think I would like to bring up some of the issues which we are having in our society. Sometimes they are not, they are not, we are not able to correct them. For example, the burden on the residents, the burden on the doctors, although we may be aiming to have empathetic view, compassionate, but the work burden is so high that in the rush in this, so we may forget, because at the end of the day, we have to finish the goals. So that is where we get disconnected from such cases, like, very sensitive, like IUD. Even the same is for even breaking bad news is not only for IUD. It is even to disclose the diagnosis of cancer in any patient. We have the HPR report, and who has to start, who will break the ice. So that is the main thing which will happen in our wards, because we will be taking rounds, and suddenly, if you have, although you'll be having some anticipatory situations, but still, breaking bad news is again the reality, as Dr. Ayesha very well told, that it is bad news, whatever form, whatever, this one you give, it is still a bad news. So one thing is that, yes, we have to be even realistic to the context in which we are working. Heavy burden in our hospitals is one major issue, which I don't think anyone can bring any change in that. Low resource setting, yes, the patient was made to wait in the ultrasound room because there were a lot of patients there. Sometimes ultrasound as a point of care test is being done in our own department. And declaring IUD is not that easy. That is why we take the help of even a radiologist. So that is where the effective communication skills come into role, because it can't, the bad news cannot be broken in a rapid manner. So we have to amp up the sensibility of the patient, because that is how even we start. It is like putting ourselves into their position. So what we start off is that, there is something wrong. We are expecting, something out of, departure from the norm. So that is how and even patients start calling her relatives also as a team. So that's why we make our team, and correspondingly, patient also will be making the team, and they'll be making calls. They'll be calling people. This is not one simple thing. So that means, again, societal, context is very important in this. Cultural sensitivity is also very important. So we can't stop, telling bad news to whatever they will give their phone. They tell somebody is there in US. Can you just speak to them? Can you just explain to them why this happened? Because that again puts another, burden, another responsibility on us, that we have to again, adjust our tone, everything, and, speaking skills, everything to that context, and have to declare. Again, putting patient at the center, whatever we are doing, here it is the patient who is at the center, heart of the situation. So again, resources have to be improved. Ultrasound, as you all know, along with the complexities of PCP-NDT, I think those who have gone through only will know that. So that has to be eased. I don't know how much policymakers can help us, but I think whoever sitting in the strategic locations, please have to help obstetricians who really want to bring good at the locality. That means we have to do everything at point of care. Although we have support departments who can help us, but point of care test is the one which will raise the alarm. It will raise the antenna in the first place. So that antenna, whoever raises, has to ascertain that it has to reach some logical conclusion. And as it is seen in Spike module, I think it should be a comprehensive thing. It is like, screening. Once you do the screening and once you see the abnormality, it's our responsibility to administer the treatment for that. Screening has to be, it has to come full circle. Unless we have the treating modality in place, we should not screen. That is my this one point here, because there's no point, just going ahead with the screening when you don't have the treating modality in place. So again, if you are diagnosing some abnormality, we should also have the channels of communication, channels of treatment in place, so that you can refer the patient also. We can't leave the patient midway. That is, again, they want to ensure that we are throughout their journey, if not physically, by virtually, whatever the help we can give. So that also has to be in place. Then again, creating anxiety, it is anxious. The situation itself is very anxious. So in that case, instead of multiple people talking the same thing in different tone, or, even slightest change also will unnecessarily increase the anxiety in the patients. So in such cases, I always ensure that one person should be the nodal person who can go outside and then communicate. None of others will speak. Because this will, again, if there is any change, any disparity in the communications, then that will highlight, and unnecessarily we are falling into litigations because of this. And most of it happens in OTs, because in OT, we know that we have delivered a sick baby, sometimes sick baby. So, but the thing is, giving that real time information to the patients and their attenders, so that we along the journey take them along to reach that reality. Even it is good for bad. I think it's a journey, it is not one point. So that journey has to be traversed altogether. You know, if there is break in the system, in the parties, then thinking pattern, that creates a lot of problem. And again, that invites litigations. Then again, using medical terminologies, nowadays even public come with lot of Google information. So this medical terminology, in fact, if we don't say, then they start highlighting that one as if we are not, able to express that one. So again, we have to be very judgmental. We have to really think whom to address, because once you are, talking to the relatives who are highly educated, then again we have to adjust the tone and tenor as per the requirement. Then again, overbearing attitude. Once there is, we doctors are oversensitive sometimes. If there is IUD, if there is any this one, then again, what we think is that we will try to reassure them that next everything will be normal. So no, we are not here to give them that this one. We have to be realistic. Because if there is IUD, there is no point telling that she will undergo vaginal delivery only. No, there should be some this one, although it should be balanced. So it has to be very realistic and it should be objective. There should not be any subjectivity. We cannot go along with their emotions, because we are, at the end of the day, we have to do our job. She will get the service and then go off. But we are here to do the job. For her, we are one doctor. But for us, we have lined up patients. And I think the same context which I can say, even postnatal, even a mother after delivery goes to postnatal ward, where there are mothers who are nursing their mothers. So this again, we have to balance this. What we do is that baby, like the woman who has delivered, stillborn, who doesn't have the baby, so she has to be shifted to some places like gynae ward where there are no babies, and she'll not have that emotional, trauma to her, because surroundings will bring lot of changes, lot of impact on the patients. So we have to, in such patients, it is better that we ask them to make their own team, so that that team itself can take care primarily of that patient. Then we can also go along with them. That patient should not be addressed independently. So that we have to ensure. And same thing, I think, to such patients, our junior doctors who are just fresh, who are in a hurry to just complete the list of jobs, so those people should not go and then take her as, one in the queue. So she is not in the queue. That should be very sensitive here. She is not in a regular queue. She will be outstanding because of her situation with her. So I think these are the ones which I want to highlight. Again, some are, which can be corrected, some are not corrected here. I think the right thing also was video was very well brought out. And self-blame, I think denial is the first step to accepting. That's what I am the international award recipient in palliative care, which we practice, because this sensitivity to this, such situations is part of the training also in essential care of palliative care. So in which case, I think when the patient is in the denial mode, we should allow her to be in the denial mode, because it is for her well-being she's doing that one. And we cannot force her to accept the reality. The reality we know, and let us manage it as per the protocols. So I think denial should be taken as the first step in accepting. So that is not the denial forever. So I think all this it should be brought. I think seniors, we know how well to manage all this, but these things have to be inculcated in the junior residents who are in their first year and second year. That's what is my concern. And SRs, being their first responders, should be more educated and more sensitive to the requirements of the JRs, and to be the link officers between patients, residents, and the seniors. So that is all from my side. Thanks a lot for having me here again. Thank you.
Yeah. So very true, Dr. Pushpalata. So many tips, and really your experience in managing the so many patients as well as the residents' attitude. That is very great. Thank you for the inputs, and it was a great contribution from your side. So thank you very much again, Aisha, as well as Pushpalata and all the team. And let us move, Vandana, for the next role play.
Shreya, please share the PPTs, CV of Professor M. Anuradha Madam.
Yeah. So next module is taking informed consent, and the experts are Dr. Anuradha from SRM Medical College and Research from Chennai, and she has got many accolades to her credit. And the next person is Dr. Mukta Agarwal, who is HOD at All India Institute of Medical Science, Patna. So she's also having more than 80 index publications, and she has got a special interest on minimally invasive surgery and infertility. So the demonstrators are Professor Sanjita Kumari, Dr. Maitri Sen, Dr. Zulfa, Harshita, Somreddy, Anash, Vaishali Shankar, Shivami, and Sanjana. So these are the demonstrators, and over to them.
Please share the
Shreya?
the video.
Can you play
The
the
video first?
We'll go
Yeah.
for the video, ma'am.
Yeah, Dr. Anuradha? Yeah.
Yes, ma'am.
Good morning, one and all. I am Dr. Sajita Kumari, professor from the Department of Obstetrics and Gynecology of SRM Medical College. Today we are going to see a role play on how to take informed consent from a patient planned for total laparoscopic hysterectomy. So we'll actually have two scenarios. First one will be a non-ideal scenario which will be followed by a discussion, and then we will demonstrating how to take a consent properly. Today we have with us Dr. Maitri Sen, Dr. Vaishali, Dr. Sanjana, Dr. Manasa, Dr. Shivagami, Dr. Harshita, Dr. Zulfa, and Dr. Vishal. So we will, our aim today is to identify what are the common mistakes that we do while taking an informed consent and understand how to take a consent properly, right? So now we will see the role play.
Dr. Vaishali, who is the next patient?
We have Mrs. Sanjana posted for TLX tomorrow.
Please call her in.
Mrs. Sanjana, please come in.
Mrs. Sanjana, you know na, tomorrow you are having the surgery. So my PG will explain you everything and will take a consent for you. Okay?
But ma'am...
No, don't worry. She will explain you. She is my PG.
Please come that way, Mrs. Sanjana. I'll explain you. Mrs. Sanjana, you're posted for laparoscopic hysterectomy tomorrow. So this is the consent that you have to sign.
What are you going to do to me, doctor?
We're just removing your uterus, not much of a deal. Just sign the consent.
But I mean, they've told that they're going to do the surgery today only, doctor.
No, you're posted for tomorrow, ma. So here is the consent that you have to read. I'll send in the pre-ops. The anesthetist will explain you about the others.
What is the surgery about, doctor?
It's just that we are removing your uterus. We won't touch the ovaries unless it's necessary. Hello. Yeah. I'll come and see to that. What else is there? Just give a pan. Settle the patient. I'll come there in another 10 minutes. We won't touch your ovaries.
But what about the risks and all, doctor?
Of course, there are a few risks associated with any surgery, right? So not much of a deal. It's just that we do it every day here. Nothing much to worry about. You should be okay. Just sign it.
But is surgery absolutely necessary, doctor?
Of course, we have a failed medical management. We have nothing much left now. Surgery is the only choice that you've got. So just follow the instructions.
What about her recovery and all?
It should take 1 or 2 days maximum. So I'll send in the pre-ops. We can proceed with the surgery tomorrow. Just read the consent and sign it once.
Oh, she's not even explaining it to us properly. It's my uterus. They're going to remove it. They're suddenly telling that they're going to remove my uterus. I guess there's no other way. I think we'll just have to sign it.
Can't understand this also.
Thank you for that performance. So now we will reflect on what we have seen. This is not an ideal scenario. You all agree with that. So what in your opinion went wrong? I would like to go step by wise. First of all, what was the problem with the setup?
Mom, the privacy of the patient was not maintained. The doctor explained to the patient in front of other people. So the privacy was not maintained.
Yes, very good. So whenever we get a consent, the setup is very, very important. It has to be in a place where the privacy, the patient should have the confidence and the privacy of the patient should be ensured. Okay, so here in this scenario, what we have seen, there were so many people standing around, there was distraction to the patient, attenders, as well as the doctor also was getting distracted with phone calls, isn't it? So the scenario should not be like that. It should be a privacy setup, has to be maintained. Yes, anything else you want to tell regarding the surgical, how the surgical procedure was explained?
Ma'am, the indication of the surgery was not explained, and the full form of the surgery is not told to the patient, and the procedure what is done inside the operation theatre clearly is not been explained.
Yes, exactly. So whenever we are explaining or getting a consent for a procedure, first of all we should tell why we are doing that surgery. So what is the indication for that surgery? And you have to tell the name of the surgery in full. Okay, and then explain the surgery in very simple terms. What is the procedure you are planning to do? So that has to be explained. So ideally it has to be explained by the operating surgeon, or at least by a person who is actively involved in the surgical team and who is well aware of the steps. Yes. Anything else you would like to add?
The benefits and the risks of the consent procedure was not explained properly to the patient and the attendant.
Yes, exactly. So whenever you take a consent, you have to tell in what way this procedure is going to benefit that patient. It is very, very important. And along with that, the potential complications which may arise have to be enlisted. Apart from these benefits and risks, we also have to tell her the alternative procedures which are available for this particular condition. So that also has to be explained to the patient, and the patient has to be included in the decision making. So the autonomy of the patient is very, very important, which was not at all taken into consideration in this case, isn't it? It was like patient was not included in the discussion at all, and they didn't give any other options, alternatives which was available for the patient. Even though the patient wanted to know what are the options available, it was not open to her. Yes.
I have a doubt. The patient wasn't given enough time to read and understand the whole
yes. Concept. So that is another point. See, what we saw here was the procedure was the doctor who was explaining the procedure was in a rush. It was in a hurried manner. The entire thing was explained to them. They were not given any chances to ask questions, and the consent form was handed over. They were asked to give a signature. So this is not the way in which you have to do. The consent form has to be given to the patient and the attenders. They should be given sufficient time to go through the consent, to understand the consent, and they should be given time to ask any questions if they are having any doubts. That time also should be given for clarification as well. So all these things has to be there while taking an informed consent, and most important thing is all this should be done with empathy. The empathy part was totally lacking in the scenario which we saw, isn't it? So in a proper manner, if you take, we should take a consent in a respectful manner through proper communication skills. There should be an empathy towards the patient. The patient should also be included in the discussion, the procedure in brief, the benefits, the risks, and the alternative methods should be explained to the patient, and the patient should give a voluntary consent, right? So now we will see how a consent should be taken in a proper manner.
Dr. Vaishali, who is the next patient? Please call. Please call her.
Good morning,
Good
doctor.
morning, Mrs. Sanjana. How are you doing?
Doctor, I'm still having heavy menstrual bleed for the past 6 months, doctor. It's not improving at all, doctor. Also, I'm having abdomen pain also, doctor, when I'm bleeding. It's not improving at all with all medications, doctor.
And she's suffering a lot.
She's my elder sister, doctor.
Okay. I understand, Mrs. Sanjana, you have been suffering for last 6 to 7 months with this heavy menstrual bleeding. And I went through all your reports, okay, scan reports, and that day also I examined you, no?
Yes,
so
doctor.
you are having a uterus with multiple fibroids, okay? And
doctor.
already you have taken medical management, which did not work for you. So in my opinion, you are left with surgery alone, and I would recommend you total laparoscopic hysterectomy with bilateral salpingectomy to be
What
the
is
best
it?
option.
What is it, doctor?
That is what I will tell you, that we are going to take out your uterus with the 2 tubes. And the uterus is
doctor.
having that fibroid, that is a tumor. So what exactly I am going to do, I will explain you. That's we are going to just give 3 or 4 small cuts on your abdomen, okay? And by the help of a camera and fine instruments, we are going to see what is there inside, and then finally take out your uterus with the tumor through your vaginal route. There are abdominal route also of doing this surgery and vaginal route of also doing this surgery. But the best option for you will be laparoscopic, because as per your symptoms, age, and this is a very minimally invasive surgery, and the complications rates are also less, and you will recover very soon with this laparoscopic surgery.
What are the risks and complications that I might expect from this surgery, doctor?
So don't worry about the risks. Me and my surgical team will definitely take care of all the precautions to prevent all this risk, but you should know about the risk. So every surgery is associated with some risk. There may be some bleeding, okay, excessive bleeding, okay, and sometimes the uterus might be attached or stuck to the adjacent organs. So while separating the organs, there might be damage to the nearby organs like your bladder, bowel, and in very rare situation, where there will be difficulty in visibility due to excessive bleeding, we might have to open your abdomen, okay, but that's a very rare situation. And another thing is, like, if there is excessive bleeding, you might need blood transfusion. Apart from that, there may be anesthetic drug risk. And post-operatively, depending upon your immunity conditions, there might be some delay in your healing, there might be infections, but don't worry about the risks. You will be fine, we will take care of it.
The surgery absolutely necessary, doctor?
See, you have already taken the medical management, which has failed for you. Yes, there are some other alternatives also, like we can take out the fibroids which are there in your uterus, but there are complications, like if there is excessive bleeding during that procedure, that is myomectomy, then we have to take out the uterus in the same setup. And again, there is a chance of recurrence. You can get again the fibroid in your uterus. There are some other microinvasive procedures where we stop the blood supply to the uterus so that the tumors shrink. That is known as uterine artery embolization. But that is also having its own risks. Okay.
But doctor,
when will she recover, doctor? This laparoscopy surgery, as I told, recovery is very fast. On the third day, she can walk back home. 1 or 2 days hospital stay. But I would like to tell her to take rest at least for 1 month, to take precautions not to take heavy weight and all.
Doctor, what about my hormones and what about my ovaries and all, doctor?
See, ovaries, as per your scan says, the ovaries are absolutely normal. We are not going to take out your ovaries, okay? But suppose we find something abnormal in your ovaries, we might take it with proper consent, okay? In that case, suppose you are suffering from some hormonal problems, then we'll take care of it. Don't worry it from now on.
Okay, doctor.
The quality of life after the surgery, doctor, she'll be fine. She will be fine because she was suffering from this heavy menstrual bleeding so long, no? So that will be gone. Okay? She will be very much fine. And regarding her sexual life, if you ask, don't hamper that also. She will be fine. She will be absolutely fine. So whatever I have explained to you till now, is there any doubts?
No,
anything
doctor.
you can ask? You're free to ask.
We asked whatever it came to our mind, doctor. Thank you so much for
Okay, so
explaining
it's
this
your
properly.
voluntary decision?
Yes, doctor.
So any time, if you have anything in your mind, you are differing from our opinion, you can take that, you can approach us. Okay, we'll consider that. If
Yes,
you're fine with whatever I have explained, then my PG, Dr. Vaishali, will take consent from you.
Yes, doctor.
Please show them the consent form.
Just read the consent once. Ask me if you have any doubts.
Yes, doctor. You explained everything in the consent, doctor. Thank you so much.
Should I also sign? Yes, yes, yes. Thank you, Mrs. Sanjana. You will be fine. Tomorrow is your surgery. Day after tomorrow, you will be walking back home happily. Okay?
Thank you, doctor.
Best of luck.
Thank you, doctor.
I'd like to thank all the participants for their excellent performance. So I'm sure that now you know how to take an informed consent in the proper manner, right?
Yes.
Yes. So always remember, informed consent is not just getting a signature. It's a process of proper communication by giving proper respect also. So whenever there is a respectful conversation, it will help to build a trust in us, and it will definitely safeguard both the patient as well as the doctor. So always ensure that you take an informed consent by explaining properly what is the procedure, why the procedure is done, what are the benefits to the patient, what are the potential risks which can occur to the patient, what are the alternative methods, and this should be explained in a proper setup with providing proper privacy, and you should also give the autonomy to the patient, and the patient has to sign the consent with voluntarily. So let's make this a part of our professional practice, how to take a proper consent. Thank you all once again.
Thank you.
Shreya, please show the PPT of training. Anuradha, madam.
Yeah. Thank you, Dr. Vandana. Thank you, Dr. Ashok Kumar and Dr. Vidya Obi ma'am for giving us the opportunity to take part in this webinar. I think our person, we have shown the role play how to get informed consent for total laparoscopic hysterectomy. And first was a role play, which is not a proper scenario where how to take informed consent. And we had a discussion with the students. Then we taught them how to take informed consent, and the role play was a proper method of taking informed consent. And our FOXY, as I think we have the uniform consent form for laparoscopic hysterectomy, which includes all information about the surgery, name of the procedure, and what we're going to do along with that, whether you're going to remove the tubes, the ovaries, everything, and what is the meaning of the surgery, and what you're going to remove, and what are the steps and descriptions of the procedure, and what are the benefits and effects of the procedure, and what are the alternatives and risks during the procedure. Everything should be in detail and should be explained in the patient's own words, and patient should be allowed to take her own decision regarding the treatment. Hello?
Yes, ma'am.
Yes. Can you show me the next slide?
Next slide, Shreya.
Which includes all the alternatives, including the medical therapy, the surgical procedures, other modes of hysterectomy, and what are the consequences if you are not going to do the treatment? What are the consequences of refusal of the procedure? And you have to explain all the risks, including the anesthesia complications, intraoperative complications, and postoperative complications. And you never do a laparoscopic surgery, you should have explain that the patient may need open surgery if there was any difficulty or bleeding during the procedure. And thank you, Dr. Vandana and Dr. Vidya ma'am, for giving us the opportunity.
Thank you, ma'am.
Yes.
Mukta, madam.
Yeah, Dr. Mukta, your comments, please.
You'll have to unmute, ma'am. You'll have to unmute yourself, ma'am.
Oh. Am I audible now?
Yes, ma'am.
So very well presented, and congratulations to the team, Dr. Sajita, Dr. Maitreyi, and the postgraduate students. Thank you, Vidya ma'am, Dr. Vandana. So it was well presented. The first part is the real scenario, which is really happening in our busy setups, where we are not talking to the patients. It's just a blanket consent. While the second part, which is how it really should be in an ideal case scenario. So as Dr. Anuradha has shown the FOXY consent forms, and we have all kind of consent forms at our FOXY website only. So I think the take home messages is first, the consent should be preferably taken by the operating surgeon herself. This is better because patient has a this is a like mutual trust and patient has a belief. Then one thing which was missing is the route of surgery. Like we are taking patient for laparoscopic hysterectomy, so we could have elaborated upon the other routes of surgery which are more prevalent maybe in the village setting. Patient has their own apprehensions regarding laparoscopy, like abdominal routes, vaginal routes, in the simple day-to-day language. then obviously not the hysterectomy, but what all needs to be removed, what is to be expected in case if we expect the adhesions or something else, then the risk in the form of immediate risk like need for blood transfusion could be there, infection, surgical site infection, which is there, and the rare risk factors which we have covered in the form of bladder or the bowel injury or the remote risk which may be in the form of wall prolapse or fistula. And the alternatives we have given in the form of uterine artery embolization and all. And then the sequelae, suppose if patient denies for the treatment, like this patient was a very apprehensive, then what could happen? She may need blood transfusion and those things. And apart from these, the medical risks, if patients have any like diabetes or something, so this will add upon her risk further. So a very good role play, and I congratulate the team and thank you, Dr. Vidya Dhobi Madam, for having me here.
Yeah. So it was an excellent role play. Main thing is the residents tend to take only signatures. They don't explain. So every point of consent form should be explained in their own vernacular language. That is also very important. It many times it might be in English or Hindi. You should get it printed in your own language. In Karnataka, we have translated all the Foxy consent in the Kannada language. So that is very important. And talking to the people, we should have empathy. They have that all concerns about and fear about the surgery, that also should be removed from them. The few of the residents I have seen that they may increase the fear complex rather than they first tell all the risks, then they will tell about the surgery. So that should not also be happen, but it should be balancing act. So we need not tell only positive, but we have to explain the risk in a firm manner that can be also tackled. So thank you very much. There are senior faculty members in the audience also. I see Dr. Sunita Mittal and I see incoming Vice Chair Dr. Sadhna Gupta. If they are there, I need their comments as well. And then vote of thank Sadhna ji joined. Yes.
Thank you, Vidya. It was excellent, and actually, it is a dire need of today's when generation Gen is actually evolving with the rapidly changing. Ours is a different generation, and generation Gen is with the WhatsApp, so the language and the communication is very, very different for our young generation, and that connect with the patient and the understanding their concern that any surgery or any like bad news, it is something, it is our routine, but it is their lifetime. Very, very important that they are going to have surgery. And we also sometimes reflect that even being senior person, sometimes with the pressure or in any personal hurry, we tend to slip on that counseling, and that is the thing which need actually again and again review what we say, that is introspection, and there is no limit to reach the that how we can connect with the person and make the things easy for them as well as for ourselves. For ourselves also it is easy. And one thing I will just like to say that any counseling should be a brief, concise, and the focused. The way something our even professional body say that it is, especially the medical legal advisor, it is so much prolonged and so much confusing that a patient also think that the doctor is actually, they don't know are too much confused. So it should be professional. It should be always professional and not very, very personal. And sorry, like word in this still, but it is something that, yes, it is sorry for the situation, but many times the patient thinks that it is a sorry for our any antenatal care. And the third thing, if I'm not taking long, that in course of pregnancy, right from the very beginning, we should make a little bit aware that all these things can happen. This is the part of course. So there's too much over
Connection problem.
People are posting that these things are the part of giving me opportunity to speak.
Thank you, Dr. Sadhna. I request now Dr. Vandana for concluding remarks as well as closing, that is, vote of thanks. Thank you, everyone, those who joined, and all the 3 role play sessions were very excellent. And I thank for the last session, Dr. Mukta as well as Dr. Anuradha. Thank you very much.
Thank you, ma'am. In the audience, if anybody else wants to speak, welcome Dr. Bharati Maheshwari, madam.
Yeah, Bharti, I see so many people, stalwarts here. So I request Vandana to
Yes,
give
ma'am.
the vote of thanks. Thank you.
Thank you. Thank you so much, Dr. Parag sir, Dr. Ashok sir, Vidya madam, all the Foxy and ICOG office bearers for giving me once again the opportunity to conduct this program. It has been a great learning experience. This topic EdCom is something which is very hard to teach, so-called theoretically, something which we need to imbibe and practice on a day-to-day basis. I hope all the 4 role plays for which the 4 medical colleges, the faculty and the students have worked really, really hard these past few months. They provide value to everybody who has been in the audience. And once we circulate it on the YouTube, whoever gets to see it, thank you so much. Thank you so much to the backend team, Nilima ji, Shreya, MCure for recording the videos. Thanks a lot. Thank you.
Thank you, Vandana. Excellent program.
Thank you.
Thank you, thank you, Dr. Sheila, for being there for all the role plays and comments.
Yeah. As you said, it's so much of learning,
It's so much here
Yeah,
learning. Yeah.
Sheila ma'am, it's open for everybody, DNB faculty, students,
Yeah.
everybody.
All the postgraduates,
Anybody.
it is open. You can open up those students also. You can bring in for the role play.
Same link they can join. No? And you are going to put it in the ICOG website or YouTube?
Ma'am, the YouTube link will be put on the ICOG website. It shall come out by tomorrow or day after. The previous 2 modules are already there on
They are
the
already
ICOG
there.
website.
They are already there. You can share
Okay.
that
I'll
link.
share the link with you, madam.
Yes. Yeah, thank you. This is very important. This I would like to share it with more and more people.
Yeah.
Today's, yeah.
Very nice.
Thank you.
Thank you.